Good morning and welcome to the third day of the fifth International Pediatric Hematology Conference. Our first speaker is Dr. Amani Al-Hajri. Dr. Amani is currently a manager of Bahrain Genome Project, previously an adjunct clinical assistant professor, College of Medicine, Arabian Gulf University, and Al Johara Center for Molecular Medicine and Inherited Diseases. She is the head of Hereditary Disease Group at Salmani Medical Complex. Welcome, Dr. Amani.
Thank you, Dr. Najat, for your nice introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me a great pleasure to be with you here to discuss our interesting topic, which is an update of on the impact of Bahrain Screening Initiative for Hereditary Blood Diseases and the sickle cell disease updates in the context of the service that we are providing here in Bahrain. So, as you know, yes. So, as you know, Bahrain has a long-standing history of combating blood disorders, and this dates back from the 80s. So in this small talk, we were going to discuss the updates on the screening initiative and the new therapeutics for sickle cell disease in Bahrain. As you know, the prevention levels are divided into three levels: primary, secondary, and tertiary. So in the primary level, we are targeting the population as a whole in order to prevent the occurrence of disease altogether. And this is through education and awareness campaigns. And I have just said that this is a continuous effort between the health sector and many other community and charity related bodies such as PINHAS. Also, BGD is considered as a primary level of prevention because we are preventing the occurring of disease. In terms of secondary prevention, we are running simultaneous screening programs that are available in Bahrain, and we are going to discuss and highlight each one of them. And the tertiary level, we are referring to the rehabilitation after the complications occur. So this is our target of our topic today because it encompasses a big population. So the Bahraini screening initiative in terms of secondary screening, and we are referring at detecting the disease in its early stages so that we start treating it and prevent the complications. The first is through premarital counseling or preconception screening. The second is antenatal screening. We have the student screening, newborn screening, prenatal diagnosis, such as CBS and amniocentesis. In regards to premarital counseling, this is one of the leading causes of this dramatic drop in the incidence of sickle cell disease and beta thalassemia. Since it has been approved by His Royal Highness the King in the year 2004, it became a mandatory measure for all those who are going to get married to perform the screening test for hereditary blood diseases that are common here in Bahrain, namely sickle cell disease, beta thalassemia, the other thalassemias, plus the G6PD, among other infectious diseases or sexually transmitted diseases that can be prevented. And thanks God, we have almost like 100% uptake of the premarital test because, as I have just mentioned, it is mandatory to certify the couples before registering the marriage certificate in court. Interestingly, in regards to the cases that we see at the secondary care, those who are referred from the primary healthcare centers, we have 33% of the referrals, the couples are indeed at risk of having affected children, while 67% they are not at risk. It is worth mentioning that most of the time, those who are found to be at risk at the level of primary healthcare, they just decide not to go further in their marriage because most of the time it is arranged marriage and there isn't any difficulty in breaking up the plan. However, it is only this minority that we are seeing at the secondary care for whom we are providing genetic counseling. When we break up those who are at risk, we found that the majority are either having, both of them are carrier for sickle cell traits, and 29% they are sickle cell trait with beta thal traits, while the others are different combination of the previous with other hemoglobinopathies such as E trait or D trait or C trait, etc., for which we are providing proper counseling. In regards to antenatal screening, it is taking, the primary healthcare is taking the responsibility of doing the whole screening processes at the MCH, the maternal child health care units. In all different health centers, we have around 22 health centers scattered all over Bahrain. So anybody or any lady who is diagnosed or has a confirmed pregnancy is scheduled for antenatal clinic where she is going to be tested for the hemoglobin pattern, the blood group, and the RH. They will do for her the CBC plus VDR, HIV, viral hepatitis, and the routine urine and culture testing. So for those who haven't done the preconception testing, they will be definitely picked up. And whenever the lady is found to have a carrier of one of these hemoglobinopathies, they ask her to test her partner or her husband to confirm their risk, and therefore they are also provided further counseling if both of them are at risk. The National Student Screen was a wonderful program that was been started in the year 1998 with a combined effort with Bahrain Hereditary Society Anemia and the Ministry of Health at that time, where plus, of course, the cooperation of the Ministry of Education. The students in grade 11 were offered the blood testing so that they know their blood status beforehand or before thinking of getting married. Since they are, at the age 16, 17, they are still not haven't thought of getting married, and so it is useful to know their status beforehand. And the program emphasized the importance of premarital counseling. All students are provided with cards that and they are provided secretly or confidentially to all of them, and they can keep it to remind them that they are, for example, carrier for sickle cell disease or anything else, or they are not. So we are proud that we have tested more than 95,000 students throughout the years of student screening. However, in the year 2014, it has stopped because of lack of funding, unfortunately. However, since we have started another parallel screening program, which is a newborn screening, so it is now taking over for the student screening. So we have filled up the gap that we were afraid that we might lose this category of patients. So this is the statistics of student screening that has been done throughout the years until the year 2014. As you can see, it is fluctuating a little bit, because it was reflecting the previous generation, the generation that has not done the premarital counseling. Therefore, we were not expecting much of dramatic change. And this is for the sickle cell disease. The previous was for beta thalassemia, sorry, and this one is for sickle cell disease. The same figures here are also as expected. In regards to newborn screening service that has been initiated in the year 2007, we are screening all newborns born in government hospitals to detect as early as possible all the hemoglobinopathies that can be detected at birth, and we provide follow-up, we provide generic counseling for the couples again, and we provide a proper referral to the pediatric hematologist through this program. And it is, of course, still ongoing. This is a graph that shows the dramatic drop in the incidence of sickle cell disease among newborn, as you can see. So the overall figure is dropping, and this is a remarkable achievement which made us outstand the countries in the region with these complementing each other programs. So the screening timeline here that encompasses all the programs that we have discussed earlier. And as you can see, we started with the antenatal screening from the 90s, and we have the student screening started in the 1998, but stopped in 2014. The premarital counseling is still ongoing since the year 2004. The newborn screening since the year 2007, and we are working on expanding the panel of newborn screening to encompass other genetic disorders. And we have lately the genome project that has been started in 2019, and we are still awaiting the results and how to fully utilize the genetic results in preventing diseases, not only the hematological diseases, but other genetic disorders. If we are going to discuss the new therapies for sickle cell disease, I'm sure our colleagues in the last couple of days, they have wonderfully discussed many of these new therapeutics agents in the market that have very promising outcome for sickle cell disease in particular. I'm here now to discuss them shortly in the context of our service that we provide here in Bahrain. The overall survival for sickle cell disease has dramatically improved over the years. If you can see this graph, we have the purple line was the earliest studies conducted in Jamaica, and the last one here, the greenish, this is conducted between 1983 to 2008 in London, and red one in the US. So you can see the dramatic improvements of survival for sickle cell disease. And this is, of course, because of the improvement of the therapeutic agents and the more awareness of this disease. This is the median survival of for sickle cell disease in the form of SS or S-beta-NAL or SD. It is around 48%. This is the darker line. And the HSBC or HSBS-beta plus have, of course, a better survival of 54.7 years. So let us discuss the conventional treatments versus the new treatments. Hydroxyurea is an FDA approved. I'm sure most of you are now aware of it. It has been approved since the year 2017 for children and for adults since the year 1998. It was noticed that it increases the hemoglobin F or the fetal hemoglobin. So And this has the advantage of not be subjected to polymerization because of the sickling. And it has the ability to decrease the erythrocyte adhesions and improve the red blood cells survival. And indeed, it has improved the crisis between 2.5 versus 4.5 per year before being treated. And the median time, of course, was improved even with the second doses. And it was first published in the New England Journal of Medicine. The morbidity and mortality has dramatically decreased. However, the challenges that we are facing is compliance or adherence to the doses, because there are many missed doses. But even if they miss it, it is just fine. Monitoring, you need to monitor the CBC within the first visit, and then quarterly. It has some issues with fertility. They have noticed increased obstetric complications with use. Therefore, it is not being advised to be taken during pregnancy or pre-conception. There are no studies that proved its linkage to cancer, so it's not causing cancer as it was thought before. However, it causes some myelosuppression. Therefore, we need to check regularly the CBC. Sometimes it causes hair loss, nail changes, and weight gain. And of course, the lab effects that we might notice on those who are taking hydroxyurea is the increase in hemoglobin F, increase in the hemoglobin, increase in the MCV, decreased WBC, ANC, and hemolytic markers such as the LDH and the reticulocytes. But it is not well studied for the other variants of sickle cell disease, such as the SBC and HBsP thalassemia. So in regards to the top new therapeutic agents, I have just selected those who are relevant to us here, but there are many, and most of them are still being investigated. We have the voxelotor, which is a hemoglobin S polymerization inhibitor. It has been granted an accelerated FDA approval in the year 2019, and EMA, which is the European Medicine Agency approval, in the year 2022. The indication in the US for adults, it is indicated, and for pediatrics, for the age of 4 and older. In Europe, again, adults are approved to take it, plus the children 12 years and above, whether it is mono or in a combination with hydroxyurea. How it acts, actually, it selectively binds to hemoglobin, to the whole hemoglobin molecule. Therefore, it increases the oxygen affinity and keeping the red blood cells in the oxygenated status, preventing it from sickling. It has led to around 40% increase in the hemoglobin in the initial clinical trials. Also inhibits red blood cells, as we have said, from sickling. It attenuates the deformity and reduces the viscosity. The brand name is Oxybrata. However, the morbidity is still being followed up and investigated, whether it is improving or not. It is suggested that it is improving the morbidity. The mortality, we still have not enough data about it. The adherence is a little bit difficult because it is a daily medication. And again, the compliance and there are some frequent side effects that makes the patients reluctant to continue with that. The lab changes shows increased hemoglobin, decrease in hemolysis marker, and it is, of course, advisable not to be taken during pregnancy. The common side effects are headaches, diarrhea, rash, nausea, and some rebound hemolysis when it is stopped abruptly. Therefore, it should be, if it is going to be stopped, should be under medical supervision. Another drug, crizanlizumab, maybe you are aware of that. The brand is Adacatu. It is nothing but an immunoglobulin monoclonal antibody used to reduce the frequency of VOCs in patients with sickle cell disease. Let us see how. Or before that, it is indicated for those who are having frequent VOCs, aging 16 and plus. So it's not indicated for the younger age group. It has a long duration, so it is given every 4 weeks. The patient should be counseled regarding the risk of infusion reaction because it is administered intravenously. It's not an oral medication. So the platelet counts might also be affected. So what they are, the way of administering it is after the first dose, 2 weeks they will receive the second dose, and after that, every 4th weeks they will continue to have the infusion. So basically, the drug or the immunoglobulins and this medication binds to the B selection on endothelial cells and in the platelets. As you can see, this is a platelet, and this is the endothelium, and the greenish blue is the medication. It binds to these receptors on the platelets and these receptors on the endothelium. These receptors are supposed to interact with the B selection glycoprotein ligand 1, and therefore initiating an inflammatory response leading to vaso-occlusion and an inflammatory response. So by blocking these B selection proteins, it will be preventing the VOC. From these two graphs, you can see this is the first sickle cell related pain crisis, and this is the second. It has a good response rate in the initial studies, especially with the high dose. It reduces dramatically the rate of VOC similarly, and the second graph. However, last year in January 27, Novartis, which is producing the drug, has announced an update on crizanlizumab. They have found from phase 3 study that there is no statistical significant difference between crizanlizumab and the placebo group. So contradicting the initial studies that made the FDA approves it. Therefore, MEHRA, which is the Regulatory Medicine and Medical Advices in the UK, has stopped it. Similarly, the European Medicine Agency or the EMA also have stopped using this medication. L-glutamine has been very popular among our Bahraini patients, taking it even over the counter before being investigated fully. L-glutamine is an amino acid, and it is mandatory for the synthesis of nicotinamide adenine dinucleotide, which is the NAD+, and it's reduced from the NADH. These molecules prevent the RBCs from oxidative stresses. So it keeps it in the oxidative status, therefore preventing it from sickling, preventing it from hemolysis, and preventing the vaso-occlusive crisis. It has showed 25% decrease in the annual pain episodes in the initial studies and 33% decrease in hospitalization. It also has been studied in a combination with the use of hydroxyurea, but mainly for the SS genotype. It wasn't studied in the S-beta and the other forms of sickler. It had gained the FDA approval in the year 2017. For both adults and pediatric patients groups, 5 years and older. The morbidity is supposedly to be decreased. The mortality is still being investigated. The adherence also is shown challenging because it has to be administered twice a day, taken with food or beverages. The fertility is still not so, they are not fully aware of it. Therefore, it is advisable not to take it during pregnancy. The cancer has we don't have any confirmation that it causes cancer. There is no lab changes related. The uptake is considered poor, and the adverse effects could be mainly GI upset. However, in phase 3 trial used for FDA approval, they have again found that there is no differences between those taking placebos and those taking L-glutamine. And it hasn't shown any reticulocyte differences in the reticulocyte counts or the hematocrit levels. So they have started doubting that the benefits of the L-glutamine, and it might not be involved in reducing the oxidative stresses in red blood cells. So this leads us to the new therapies, the curative intent therapies, the therapies that will cure the disease altogether, whether it is sickle cell disease or beta thalassemia. We have two categories. These are the bone marrow or stem cell transplants or gene therapy, and both have advantages and disadvantages and differences in terms of manipulating the stem cells before or just transferring them altogether from a donor. So allogenic hematopoietic stem cell transplants is not something new. It's been there since the 80s, and it is quite interesting that it was discovered incidentally in relation to sickle cell disease. There was a girl in the US who had developed acute myelogenous leukemia, and they decided to do for her stem cell transplant. So it has been done for her, and she was indeed having sickle cell disease before. But after being transplanted with stem cell, the sickle cell disease has disappeared. So it has been since then used to treat sickle cell disease and beta thalassemia. We need either to have an HLA matched donor or a haploidentical donor. Haploidentical donors, we are referring to a relative sharing almost like half of the genes, such as a sibling, a mother or a father, or an offspring. The indication for stem cell transplant is developing stroke, recurrent hospitalization, exchange transfusion for acute chest syndrome, and recurrent VOCs, that is more than 3 episodes per year. Sorry. And of course, research has demonstrated the benefits, and the earlier, the better in life, especially before the age of 10, because it has been linked to a lower risk of death and lower overall healthcare expenditure if it is conducted earlier. However, there are always trade-off of, between especially in consideration to myeloablative approach versus non-myeloablative. And when we are talking about myeloablation, we are talking about killing the patient's stem cells before doing the transplant. Okay. And there are issues regarding the two approaches. For myeloablative, we have a higher incidence of end organ toxicity as compared to non-myeloablative. However, the graph is more stable, while here it is non-stable. And the challenging thing is that we don't always have a matched donor. We have only 14% of the time when we have a matched sibling, which is the optimal donor in these cases. In regards to gene therapy, we are talking here about manipulating or editing the gene, the defective gene. We have two approaches. We have the traditional gene therapy, and we have the gene editing approaches such as CRISPR. For traditional gene therapy, we are basically taking a normal gene. In the case of sickle cell disease, it is beta globin gene, and we insert it into a viral vector. The viral vector usually is a lentivirus, where we are ablating, we or remove the genetic material from the virus and insert the desired gene, and then we infect the stem cell. The gene the gene here, the genetic material goes into the nucleus and gets integrated into the genetic material and starts producing the normal globin gene. While in CRISPR gene editing, we are actually removing or adjusting or editing the mutated gene and making it a correct gene. So it starts producing a normal protein. So the idea is of having gene addition or gene editing, and both of them have some advantages and disadvantages. In regards to approval, the FDA has lately approved 2 landmark cell-based gene therapies, the Vertex Casgevy and the Bluebird Bio LifeGenia, for the treatment of sickle cell disease. And it has been released here just in the last December 2023. However, the cost is hindering the widespread use of gene editing or gene therapy. For Casgevy, it costs $2.2 million, and for LifeGenia, it costs $3.1 million for the one-time infusion, and most of the time they need more than one infusion. So it's not only about the cost, it's also the access. To administer these therapeutic modalities, we need in approved or accredited centers by the mother companies. So it's not feasible for everyone. And the risk of myelodysplastic syndromes or acute myelogenous leukemia is always there. And it has been reported after both transplant and gene therapy. The impact on fertility also is another concern, because it can indeed affect the future fertility. The issue of non-myeloablative and the reduced intensity regimens is still under study. So summing up together all these medications and therapeutic modalities, if we plot them for efficacy against the risk, access, and cost, we will be looking for a drug that is ideally located here in the graph. So far, we don't have any medication lying down here. The closest is hydroxyurea. So it is the safest, the most efficient, and the cheapest. Okay. However, the L-glutamine lies down, the voxelids are here, the crizanlizumab is here, and the gene therapies and transplants, curative therapies are still far away from being ideal. So where do we stand here in Bahrain in regards to these new therapeutic agents and how we are going along with these modalities? In regards to Vixelator, Salmania Medical Complex under the government hospital has started randomized controlled clinical trials, and it is part of phase 3. So we are being part of the global efforts to study this medication, and hopefully it proves good. But in regards to L-glutamine and crizanlizumab, NEHRA, however, stopped or has not approved it because of what I have just mentioned in phase 3 trials. Both of them are having no differences between the placebo and the treated group. Therefore, it hasn't been approved or to be used in sickle cell disease. What about gene therapy? We are blessed and we are lucky to have the directive from His Royal Highness, the Crown Prince and the Prime Minister to approve the use of Casgevy, which is a gene therapy. We are considered the second country in the world to approve it and the first in the Middle East. So we are happy to start filtering the patients, the candidates for gene therapy. And just a couple of days, we have wonderful breaking news that Bahrain Oncology Center in King Hamad University Hospital has gained the approval or the accreditation by the KSKV to provide KSKV from the Vertex company to treat sickle cell disease and beta thalassemia in Bahrain. So some good news after all, alhamdulillah. There are some other future treatments in the pipeline. I'm here listing two that seems to be very optimistic, and of course there are many other medications such as Brusergel and Metabivat. So we will be waiting for the news, inshallah. So to summarize my presentations, alhamdulillah, thanks to God, the incidents continue to drop here in Bahrain as well as globally. Bahrain is one of the leading countries providing approved therapeutic options, and there's a great hope on the horizon to eradicate hemoglobinopathies altogether. Thank you very much. Yeah, any questions?
Thank you. Yeah. Thank you so much, Dr. Amani, for the excellent presentation. There is one question. What are the criteria of the HB newborn screening for referral to hematology, and how is the data from private healthcare screening captured by the Bahrain database?
Sorry, I did not follow up. What is the criteria for?
What are the criteria of HB newborn screening for referral to hematology?
Yes, actually, what they are doing for newborn screening, that there is an HBLC test conducted by the pathology department for anybody who's been detected, regardless of the CBC, regardless of the hematocrit and or the full CBC count. Whenever they find that there is sickle cell trait or disease, or an indication for, or some indication that the patient might have some hemoglobinopathies from the HBLC, they will be referring the couple for CBC testing. Okay, so it's not part of the screening to do the CBC. And accordingly, since it has been done by a physician, the CBC will follow the usual pediatric hematology criteria for further investigations and management.
Okay, thank you. Thank you so much, Dr. Amani. And we move to the next speaker, Dr. Dikra Al-Khayyal. Dr. Dikra, she is consultant pediatric dentist, King Faisal Specialist Hospital and Research Center, and joint scientist, cell therapy and immunobiology department, King Faisal Specialist Hospital and Research Program. Coordinator Department of Dentistry, King Fahad National Center for Children Cancer, Head of Scientific Council in the Saudi Board of Pediatric Dentistry in the Saudi Commission of Health Specialists, and Secretary of Dental Committee, World Federation of Hemophilia. Welcome, Dr. Dikra.
السلام عليكم دكتورة كيف حالك؟
عليكم السلام ورحمة الله وبركاته.
I want to thank you and your organizing committee for always coming up with an excellent program and also including me in it. But I'm trying to put open up the share. The problem every time I don't know how to share. No, and I don't know why I'm not getting the sharing. Can you allow me to share? Is it okay?
You are allowed, doctor, to share your presentation. From share screen, you can see in the top or down menu, share screen.
I'm trying to find it. I really apologize, but I will not take time. Yeah, I found it just now. Okay, because before I think it wasn't there. Can you see it? Yes?
Yes, just to minimize the web page.
Okay.
Yeah.
Again, thank you, Doctora, for really leading, leading the advances or emerging in the care of bleeding disorders and all other congenital and genetic diseases. My speech today, actually, it was given to me as dentistry pivotal role in the management of bleeding disorders. And of course, when you look at it, you would say, what does it mean, dentistry pivotal role in the management of bleeding disorder? For me, always, I try to keep what they, like from Dr. Dr. Mahdi and her group, what do they really want as a hemophilia, taking care of hemophilia and taking all, and even this model fits all other diseases, sickle cell, who are going to go for bone transplant eventually, thalassemia. But the major issue now, or not the major issue, the major issue that basically cause more issues are in patients with inherited bleeding disorders, patients such as hemophilia, Glanzmann, rare bleeding disorder. And actually, I'm proud to say I've been in the field for a long time and in the dental department, and of course, taking care of a lot of other patients, healthy, special care. But I grew actually very interested in dealing with patients in the hematology and oncology world for a simple reason that is one of the groups that have special people of hematologists and nursing that will actually have the model of care or the vision that I have for others also to include. You know, my goal here is to teach dentists as much as I'm teaching hematologists and nursing. So we have very good support. It's a special care of group of patients, and we have special support. And also with the emerging therapies, things are getting easier for us as dentists. So I would be going around telling you about nothing changed in dental disease. You know, you may have changed a lot, but dental disease continue to be the same. And also the cause is the same, and the incidence is the same all over our GCC countries and the Arab world. And we'll talk about multidisciplinary approach, dental home, prevention and treatment. We'll go some case scenarios. I've put this picture before. Actually, this was my pivotal time when I decided I will push for the prevention model in this group to the maximum, and hopefully I will have people in my dental area, whether here in Bahrain, in Emirates, in Egypt, to actually have someone who continue, whether it's a nurse, whether it's a dentist, pediatric dentist, with the same thinking that hopefully will get at least to eradicate or actually reduce the incidence of dental disease. And that's to have quality health care and reduce diseases. Reaching out to all of you, and you reaching out to me and to others to make sure that something like a dental disease should not be part of the equation. Probably most of you've seen it, maybe in your children, in your patients. We do, the most common dental disease in children is caries. We have also periodontal disease, but the major disease is dental caries. And dental caries, basically, it's what causes dental caries is many factors that play around, but mainly you have plaque, which is like the layer, the debris that accumulate in our mouth. And then there's a bacteria there in our mouth that starts at age even before the teeth have erupted, but mainly a certain kind of bacteria starts after the tooth eruption. It becomes more and more and more if we feed it with sugar, or sugar that we all know. So technically, this is really the model of how dental caries happen. Similarly, the dental plaque helps in the inflammation in the gum, in the gingival tissue. This same debris causes inflammation in the soft tissue around the teeth that will give you this redness, or which actually a major cause why a lot of patients in our children population suffer when they say, oh no, I cannot brush because I bleed. we all know, or I know, that hemophilia and other inherited bleeding disorder, they do have a risk of developing dental caries, but actually they're not any different than any other rest of the world in developing for the causation, but can pose a potential challenge when we come to manage it. And most of the children that I've seen, and the mothers, you know, also it's our attitude, but I think it's changing over the years with our efforts. They neglect oral hygiene because they worry about the fear of bleeding when brushing. And this can happen actually in patients with hemophilia. It's something to do with leaving the plaque, but actually patients with platelet dysfunction such as Glanzman, yes, it's there, and it's changes from the time depending on the disease, but the management is there because we have toothbrush, we have chemical ways. But the idea is I'm not gonna brush, I'm worried my mouth will bleed. Yes, it will bleed, it will stop, but if you brush from the beginning, there will not be.
دكتور الله يبارك فيك. الله يجزاك خير. الله يبارك فيك. تسلم الله يحفظك. هو فيرتشوال ها؟ فيرتشوال. اوكي ممتاز.
Also, the fear of going to the dentist, as is the fear of excessive bleeding after anti-dental treatment. And we have seen this in our group with our study, which is not unpublished, for quality of life. They worry about going to the dentist. When we're talking about the dentist, they're talking about the dentist outside their area, which I think now is the time to start looking at these patients, trying to take in primary healthcare. As I said, caries is dental caries is an infectious disease. It starts with a primary infection by mutant streptococci, may occur in the predentate, and these infants will can require it vertically from the mother or care provider, and horizontally from their colleagues in the school. So it has different, but mainly the vertical is very main cause of dental caries. And we always say if the mother has caries, the child, we put them immediately in the high risk group category. So it seems to be that improvements in the prevention of dental caries may likely be realized through intervention strategies that focus on the natural history of this infectious process, which basically before the tooth is actually come out. And many areas, including ourselves in the GCC and MENA area, we are promoting or pushing for the first oral exam recommended at the time of the eruption of the first tooth and no later than 12 months of age. This is shared by the World Federation of Hemophilia. All the other entities sees the importance of this model of care to be started very early on age, regardless of the possibility of difficulties is might to find access of care, because as we know, the number of dentists or pediatric dentists or pediatrician may be less than the population. So this needs to be looked upon and ascertained through government, through ministry, to be looked upon how can we actually do this in this special group of patients, which can be done because we do have the great model of care that will allow this preventive model. And you can see that in the actual medical care when our children now they can grow up to see that they may have a normal or semi-normal life with all the advent and all your work as hematologists and nursing. So what is dental home? It's the same as a medical home. It's a concept that's basically a relationship between a dentist or a physician or other and the patient. And in our situation, I think the parent have to be in that equation, very important, because they are very important people who may make this model work. Delivered in a comprehensive, continuously accessible, coordinated, and family-centered. What we do there, basically, we start telling them from day one, don't share spoons, you know, mother, don't use the same spoon. You clean your baby's tooth, gum before even after each feeding. with water. When the teeth comes, start brushing with a smeared toothpaste, which is like a rice paste toothpaste because it has fluoride. And as they get older, you start using pea size, and also start teaching them, getting them used to how to use flossing and how to use medium toothbrush as they get older. Prevention in diet, nutrition, these are important facts that are shared. Healthy body, healthy mouth brings you healthy people and a healthy teeth. So you're supposed to not to feel fall in the bottle. It's a habit. Put water. You should stop drinking from the bottle. Encourage drinking from bottle, from the cup, and snacking, and avoid sharp and hot food. And you work with nutrition to allow we all love sweet, but it shouldn't be all the time. It should be done in the mature and healthy way. We talk about healthy body, healthy mouth. Fluoride is important. It has been becoming more important over the years. Before, they used to tell us not to use fluoridated toothpaste in the mouth for children less than 2 years. Now it seems to be the saying that you can use it. It's very little amount, not all the time. Wipe afterwards, because fluoride is found to strengthen the tooth. The teeth, and make sure that helps in the overall equation of oral hygiene, improving oral hygiene and diet. When we meet with these people, we give them individualized preventive health program. I feel this until now. I think not to put it in your area, but I do believe if we try to come up with a preventive program, which we talked about it, is to start it, even if we start at the time, if you don't have a dentist, any dentist can do that. It's not a big deal. There's no risk, nothing at all. But if not, we can do it through nursing, through us, through the hematologist, at least part of our plan or roadmap. There is recommendations that I come up, I probably came up with it based upon literature from the American Academy for any healthy child, and I just added to it what specifies more or a higher risk for caries, to make sure that we kind of have a roadmap or pathway for these children. So basically, it should be part of comprehensive care management. I know all of you want that. I know you are feeling you help, but the issue is access and having the right person taking care of this at this moment. For dental procedures, I have spoken that not every dental procedure are likely to cause bleeding. And personally, with the new prophylaxis and the other drugs, and I was reading in the literature, there's not a lot of literature on children regarding that, but personally, I have done now many cases that I feel, I don't want to say it, but even with extraction and using the right methods of how to inject and what you use, and of course, I have a support at the back, but the patient is taking his prophylaxis or even not taking his prophylaxis, that you can do a lot with simple even the invasive procedures in children. We're not talking about primary teeth, not necessarily permanent teeth in children. Primary teeth, you can do a lot with minimum intervention systemically and just locally. So there are many procedures that you can do and unlikely to cause bleeding unless you hurt the gum, and then you can stop the bleeding. And there are some with low risk and there are some with higher risk. This is also adapted from the Scottish guidelines on patients for taking anticoagulant, that table. So as I said, there are things that we should go ahead, no issues. This is well written in the literature. There's no issues to be dealt with. And some of things that you may ask and think, because there's variation from patients with mild hemophilia to moderate to severe, and also because one patient differs from the other and the way how they handle things. And there are things that have a stop, a consult. The dentist should not do anything except with your approval and very close plan for this. Personally, I believe, which you're doing as a hematologist, a great job that dentists don't even know about it, is the emergency and emergency treatment. I think emergency treatment, most of these children or most of these family, they don't know what to do when they have dental pain, and they don't know what to do when have trauma or have bleeding. And I think, this is still, we are doing the job of giving them factor, and although maybe with local hemostasis, such as the tranexamic acid and other, maybe we can control it if it's not, it's not like real trauma, just simple tooth eruption, tooth exfoliation. Pain and swelling, as you all know, paracetamol mainstay. Sometimes we use codeine with paracetamol, non-steroidal are contraindicated in the books and papers. Antibiotics, we treat these patients as normal. There's nothing, dental gram-positive general antibiotics. As I said, preventive, we have no issues. Periodontal, always when you talk about periodontal, we always look at these children as we are us. We think it's going to bleed. Children, generally speaking, they don't have much calculus up to 13 years age. So that most of their issues are bleeding because they really don't brush the plaque on from their teeth. So this is very manageable starting from a chemical point of view, using chlorhexidine before I even do the prophylaxis. The same happens for patients who have calculus. There is a way to handle these patients by using chemical, being slow, where areas that need more intervention subgingivally, then you will need to, when you have to go inside, then maybe you will need other forms of systemic, depending on if it's major or severe hemophilia. Orthodontic, nothing wrong with it. However, if oral hygiene is not optimal, they should not do it. I don't feel I think for me, the pivotal or the change that happened in dentistry is related to the fact those patients in our countries are actually receiving prophylaxis. So really, sometimes we are probably over treating them for our procedure. And personally, I think these are the things we should look into, that cost effective. What are the things? If the patient is taking his factor on a certain time, it should be done like on the day, 1 hour before, rather than 2 days before, to improve. Because personally, and this is just experience, is not, I don't want to, I have done now more than 10 teeth extraction, primary tooth extraction, using infiltration and nitrous oxide. And at one point we didn't have tranexamic acid. There was, and I followed up on the phone with the mothers, there was no issues whatsoever. And so I think, we are with this new thinking, we're not using blocks, we are trying to use long-acting materials and inhalation analgesia, that we can improve, that we do the what I call the more important use of the materials for more important things. But at least for children, I think if we do a proper planning, using local tranexamic acid as a rinse solution, timing, not start like after I do something. No, I start prior, 2 days, 1 day. There's nothing to say. Now we say 2 days, 1 day, at least they say 24 hours at least for the solution, or we say 2 days because some of them, they don't use it 2 days. So to optimize the area that we're in, if we remove teeth or do anything related invasively. We have a lot of local measures now, starting pressures, sutures, splints, collagen, Surgicel. We're teaching our dentists, but this teaching, it's not as much. These are the guidelines that we use in the King Faisal Hospital Research Center. We look into pre, during, after. Of course, our work is greatly supported by great hematologists That's I think the more comfort. But now we're starting to kind of say, what can we do to help out? And I think with newer drugs, there's a lot to have to really do study. I hope I will be able with my group to do it, is to look into really these medication drugs. And when we do restorations, of course, not restoration, for doing invasive procedures, what do we get? What kind of bleeding? Of course, not every child differs, but at least we can look into reducing the amount of drugs that we're using for these patients, and look into more the local hemostasis and IV and tranexamic acid. Many guidelines are there. I have to tell you, the principle is ideal management, as they say. And as I explained before, the chronic care model in the caries development can be very, very nicely managed in this group of patients, both of them, whether it's sickle cell, whether it's thalassemia, whether it's hemophilia, whether it's Glanzmann, and they differ from one person to other. It is very important recommendation. The word federation is very important. And I have mentioned this before, having a dentist in this what's so-called multidisciplinary approach or comprehensive care is very important in our country, because we do still have I don't want to say endemic, I don't know, endemic, epidemic, I'm not good at epidemiology, but it's very high, even though caries rate, even though we are trying very, some efforts from here and there, but it has not been reduced. So at least in this model, we can try to attract a dentist or a hygienist or anybody who can do this preventive model, or even a nurse that can do a preventive model. That doesn't really need a lot, except understanding what they need at different levels and being able to interview the family, motivational interviewing. Now we still, even in our hospital, I have started with my group to start to get patients who are very young to come to us. We're still on the curative model of care, but I do believe, inshallah, one day, inshallah, if I continue with you every year, is to have a result of this model. Just a clinical case, something like that. This patient doesn't need any intervention from anywhere. He can go to any dentist. He can use fluoride or minimum without any kind of systemic or local intervention, as long as the behavior management is there. Our issue is, even that, you don't need to put him under general anesthesia to take care of him. You just need to see him every 3 months or every time he comes to you. A 7-year-old, this is probably, you've seen it before, it's in my favorite picture. It was managed purely by tranexamic acid. I use sometimes adrenaline in the local anesthetic, and it's due to the shedding of the teeth. And it's basically, it's a combination of a chemical, local hemostatic, antifibrinolytic. And then if nothing works, then, we have to, of course, we cannot not deal with it without our colleagues in hematology. There's a study to say that highest rate of oral hemorrhage was associated with exfoliation of primary teeth and tooth eruption. Should be noted the natural dental exfoliation as well as assisted exfoliation does not require hemostatic cover, and that's my own experience. Finally, this bottle should be stopped, and basically this patient has lower left need pulpotomy. We try not to extract teeth. We try to do restoration for teeth. Even if we do pulp therapy, usually this patient, for me, he's mild, and for me, personally, it doesn't have any bleeding risk. Low. We keep hearing desmopressin. In reality, I haven't been using this. I've never used it during my 27 years in King Faisal in my dental, but we use more IV tranexamic acid or systemic tranexamic acid. The IV is because we make sure the parent are taking it, and also we don't, especially in severe, we make sure that we have enough dose when we do our treatment. And we use articaine infiltration. I'm away from dental blocks, even for extraction in primary teeth. Impairment, until now, we still need the need of factor replacement when we do blocks. I want to continue or conclude by saying, the emerging, emerging therapies, dentistry hasn't changed, but it's easier to take care of patients with bleeding disorder. And it should be like starting to look at primary health care as our goal for these children to go to a dentist who can start from very young age, a pediatric dentist. Hopefully that we have more pediatric dentists, more healthcare providers. But we should say that with patients with bleeding disorder or any other, that oral health is part of general health and will impact the quality of life of these patients. I'm sure many of you know that. Thank you so much for everyone. I hope I kind of added to your knowledge. I'm happy to receive any questions, or you can contact me or see how can we work with each other in your area. Thank you so much, Doctora.
Thank you so much, Dr. Dikra, for the excellent and very impressive presentation. And let me see if there's questions from you. Okay, there is one question for you. For multiple caries, do you encourage them to do the general anesthesia to fix them, or would you recommend GA for the patients with multiple dental caries?
Very good question. Usually our issues with children, number one is behavior. So we all depend on the person who's taking care of these children, because we have variation of behavior. It's not to do with your, if I have, generally speaking, if we have 10 teeth and more, we prefer to do under general anesthesia. Also, because of the nature of these, if I'm doing restoration and simple, I don't think we should be doing general anesthesia. It's all depending on the physician, a dentist who's taking care of that. But generally, if you have multiple extractions, instead of bringing the children, like you have all the teeth extraction, some of them come of us, for instance, 50 teeth extraction, instead of giving him, actually, Doctora, it's related to the behavior. I must say, even now, if the behavior is good, most of our children actually, because we deal with severe hemophilia, are on prophylaxis, most of them. So we can deal with them on an outpatient basis. There is no recommendation because of bleeding disorder, but some of the literature say because one preparation, one area, it's better to do it under general anesthesia. But for instance, if a patient has less than 10 teeth that needs to be taken care of, I wouldn't go for general anesthesia. So it's not related to the actual procedure. It's related to the behavior. It's related to the number of teeth that needs to be taken care of. Does this answer the question?
Yes. Thank you so much, Dr. Dikra, for joining us. We move now to the next speaker. Our next speaker is Dr. Mariam Abushiel. Dr. Mariam is currently a medical genetics specialist consultant, and she did her fellowship program, medical genetics and metabolic disorders at King Faisal Specialist in Riyadh, 2 years duration, and scored the highest in the end of the fellowship exam. Clinical attachment in Manchester Center for Genomic Medicine, St. Mary's Hospital, Manchester, UK. Welcome, Dr. Mariam.
Good morning, everyone. Thank you, Dr. Najat, for the introduction. And thanks also the organizers for giving me the opportunity to present in this really amazing conference. I just want to make sure first that my screen is being shared. Can you see my screen?
Yes, Mariam.
Oh. So moving on, first of all, I don't have any disclosures to report. And my objectives for the presentation today, we will be talking first about what are the really challenges that we are facing now currently, especially in this genomic era. What are the various emerging technologies? And I will be talking about one of them, which is the artificial intelligence. and how can it be used in various medical fields, especially which are related to genetic. And I would just go briefly about how it might help in the hematological field and going finally through some of the limitations. So first of all, let's talk about the challenges that we are facing. Worldwide, it is believed that there is around 300 million people that are suffering from rare disease. And out of these 300 million people, at least 7 million of them are neonates that are born with really serious and complex disorders every year. So really, they are called rare, but collectively they are not rare. And yet they remain the health orphans of the medical system. So now it is believed that there is around 7,000 rare disorders, and this number is being increasingly annually with more and more new rare diseases are being described annually. And it is believed that at least 80% of these rare disorders have a genetic component. 50% of them affect children, and they can be really serious enough that it can cause them to die, at least 30% of them to die before the age of 5. So collectively, if we will say that those who are affected with rare disorders, they might even account for the third largest country in the world. Now, what is really the definition of rare disease? This can be really varies globally. For example, in the United States, the rare disease is considered if it is the disease have a prevalence of, let's say, less than 200,000. Whereas globally, we will say if it is affecting less than 80 individuals for every 100,000 population. And there's also a new definition of an ultra-rare disease, where it will be affecting one or less in every 50,000 population. So most of these rare disorders really cause a very serious challenges, not only for the researchers, for the health professionals, but also for the policymakers, because these disorders not only really affect the health and the social well-being of these individuals, but also might cause them a financial burden. So why is there a long process of diagnosing these rare diseases? First of all, because of the initial symptoms recognitions. Sometimes even however the expert, the consultants are, sometimes they will have very difficulty linking the symptoms between the different organ systems. Or sometimes, and that's also, or sometimes it depends on the referral system of the country, so that they can refer them to the concerned specialist. Other than that, you have to repeat many specialized tests for confirming the diagnosis. For example, even for us, for the genetics, sometimes we will ask for a single gene, sometimes we need to go to panels, but now with the WES and the whole genome, we have even developed even the tests that are being used to confirm the diagnosis, even though still we have lack of cases that have reached their diagnosis. And finally, also we need collaborations with the rare disease centers that can really deal with the treatment of such disorders. So it is believed that at least 25% of the patients with rare disorders, it takes them from 5 to up to 30 years until from the onset of their illness till they reach a diagnosis. And some of them haven't even reached, even after all this improvement in the diagnostic technologies. There's a survey that was conducted by NORD, which is the National Organization for Rare Disorders, for around 1,100 individuals. And 50% of these patients attributed that it was due to lack of knowledge about the disease that there was a diagnostic delay. And 42 believed is because there was limited medical specialized in this field. And also another survey, which was conducted over 1,000 people that were living with a rare disease, 28% of the participants waited 7 years or more for an accurate diagnosis, and 38% of these received even misdiagnosis during their journeys. That's why there is a many collaborated globally movements. For example, just an example about the Rare Disease Day, which is conducted on the 28th of February in each year to just throw a light on the challenges that is really posed by these rare conditions. And that's why also the very many health professionals working along with the leading edge companies are doing campaigns, educational campaigns, to not only educate the people, but also the health professionals about these rare genetic diseases that we are being discovered, so that anyone can keep them in mind. So one way to meet these goals was also by developing solutions using the artificial intelligence. So emerging technologies have significantly improved the research and treatment of various rare diseases. So the artificial intelligence, what is it? It is a technique that enables machines to mimic human behavior. So it includes recognizing objects in images, making decisions based on complex data. So there is subfields also in the artificial intelligence. There is what is called the machine learning and the deep learning. And this is really sometimes very difficult to understand or differentiate between the two. I'll just try to make it as simple as it is, because it is not very easy. Machine learning is mainly by using algorithms to analyze data and making prediction based on identified patterns. Whereas deep learning is a very more complicated part of the machine learning, where they mimic the human brain. There is multiple layers of neural networks that they learn to try to do presentation of the data in a hierarchical manner. So the representation of for the representation of the data of the machine learning, there is need to be a manual feature engineering, whereas the relevant features are selected or extracted by human experts. Whereas the deep learning, they're using most of rare data, and this will bypass the need of this manual feature engineering. The data requirements in the machine learning is mainly structured and unstructured. When we say structured, it means defined variables, like data that you can easily collect. Numbers, whereas the unstructured, which is mainly the deep learning deal with, is like images, audio, text. It is very difficult to deal with such data. So machine learning usually will struggle if you give it a huge data, whereas the deep learning, it will even be more and more beneficial the more data you give, you provide it with it. The machine learning is very easier to interpret, whereas the deep learning is, as I said, it is a very complex and will read a really large number of parameters. So how we use it in the healthcare? So again, the healthcare system, as we all know, they are collecting a huge data. We have a huge data about the patients, their demographics, what are their medical conditions, what are the treatment they are receiving. And as I mentioned earlier, some of them are structured, for example, lab values, the patient demographics, or unstructured, again, images, clinical notes, reports that are usually written by medical professionals, so there can be variability. So the amount of data, as we mentioned, is large. So really, we need to introduce the artificial intelligence to extract information and recognize patterns from this data. So how can really this AI help us in various, first of all, in general, how can it help us? It can help us for predicting diseases and risk stratification. By analyzing the electronic health records, the genetic data, if it was really incorporated into it, the medical imaging, one can really try to get a pattern from it and predict the risk of diseases, for example, cancer, or other monogenic diseases. We'll be talking about the complex coming on. So it can be monogenic or complex disorders. And also why it will help us, because it would really help us to identify really who are these high-risk patients. And it will help for proactive implementations and complication prevention. And there is a huge now emerging field, which is the personalized medicine. Now we are moving from what we call is one treatment for all,
Mariam,
more
sorry for
personalized.
interruption.
Yes,
Could you please go for the slideshow?
slideshow
Yeah,
now,
yes, it's fine.
here.
Yeah.
Okay. So we are really moving from now, which for a treatment would suit all, into a more personalized medicine. So IE will be needed. And as you know, now with the improving technologies, there is even remote patient monitoring. There is applications that can be seen on your watch, in your mobiles, and then they can monitor your vitals. And I heard that even because they can sense even if you are in danger, and I heard even that even they are some, I'm not sure if it is applicable for all, they can even connect directly to the healthcare facility. Deep learning, it's much used in, especially I have seen it in the radiological field. So they can analyze medical images such as X-rays, CTs, MRIs. It can use in the pathological fields by analyzing histopathologies or even real-time imaging. Now AI has been even introduced into surgeries, you know, that they can even practice what exactly they have to go, where they have to approach before doing it in the real. So it is really much advancing. Now coming to my field, which is the genetic field. With improvement in the technologies and with the next generation sequencing, the amount of data that is really generated from doing these tests is really huge. And as we heard earlier into the morning from Dr. Amani, that even there is a huge projects by country-wise that they're doing genome projects for their population. So you can really imagine the amount of data that will be going to be generated, how this data is going to be analyzed without introducing AI, for reducing the complexity and the time that will be taken for this variant interpretations. Again, how it is helping us, as we all know, when we are requesting a genetic testing, we always get the results classified into 3. So it is either pathogenic, likely pathogenic, or VUS. VUS means you are uncertain. It is still this pathogenicity of this variant. It is not really well understood. So there are still some predictors that can be used, but still this field is in early stages. And I am sure with the more and more data that is being collected, AI has to be introduced for this genetic variant calling and classification, which will eventually help us in diagnosing. So there is many online platforms that sometimes even we are as practitioners, we use, to really estimate. For example, there is a platform, I'm just giving an example of Versome, where they use AI, to predict how this variant that you are of concern is of importance. And also this, when we're talking about monogenic, when we come to complex disorders like diabetics, cardiac diseases, AI can integrate your genomic data, what we call the genome-wide association studies, with your polygenic risk score to really give you estimation of how much you are predisposed to these complex disorders that you are very usually difficult to be predicted, like diabetes, again, cardiac, psychiatric disorders. Potential treatments, drug response prediction. This is what I was talking about, pharmacogenomics. Why is it for the same medications that a group of people will have the desired response, whereas other various groups may have no response, or the other way? They might even develop serious side effects. So many of these medications are really related to your genetics, and it is really important now to start thinking seriously about integrating this information into our daily practice. It is also have been increasingly employed in the development of new diseases. It is designed for more effective and efficient clinical trials for rare by choosing the most suitable patients for these trials, depending upon their genetic component, how we think that they will benefit from it. So it helps us in really identifying new potential treatments. One of the fields of genetics is also dysmorphology. Okay, and again, there are many new platforms that have been newly introduced that at least they say that they can diagnose rare disorders using a photo of the patient. So soon these photos, I will see what are the benefits and what are the limitations of it. It can help really in combination with the genomic testing to help us to reach as much as we can an accurate diagnosis. At the end, we really are aiming to help these patients. It might help us in reducing the time, the cost, and in this diagnostic odyssey, but make sure that you notice how it is easy to take a photograph, and this tool can be really abused. So proper regulation and distribution of such tools should be very important looked into. And keep in mind, in whatever you use of these platforms, no algorithm will ever replace the expertise and judgment of the trained medical professional. Just an example of a study that I came across where a group of ophthalmologists, they have investigated the sensitivity and specificity of one of these platforms that is called Face2Gene. So they have analyzed using these platforms 350 photos, and they have taken it from books. So the exact diagnosis was identified in 150 of these cases, or at least we were kept in the first 3 differential diagnoses. So again, what are the disadvantages? The accuracy. It is a really relatively new. They might not have enough data. It must be an imperfect way. Ethical concerns, because it is related to privacy, how the consent was really taken. And it will also cause potential discrimination against certain group of people. So the lack of regulation will pose a risk for vulnerable populations, such as those with mental health conditions, which can lead to discrimination, as we said, and it will also may lead to inappropriate medical diagnosis or even push to unnecessary treatment, because what the AI platform suggested, you're going to follow it. So they might receive false diagnostics, and it will have even a negative emotional impact, and a wrong genetic counseling might be given to these families. So again, it can never really replace the examination and advice from a trained health professional. I came a very recent study, 2024, done by the Baylor team. They have created the platform called Marvel, and I think it's from 2017, and it was publicly available website. And they have integrated information now using AI from 6 human genetic databases and 7 model or organism databases, examples like OMEM, ClinVar, some of them we know, and some of them I haven't heard of. So this platform uses a machine learning classifier trained on over 3.5 million variants from thousands of diagnosed cases earlier, so that they can help to reach to the most likely gene candidate using this rare disease. There is an FDA also, if you can check, they can give you the most updated AI ML approved platforms, and the number is really increasing. Like we can see that up to date, the FDA has authorized around 882 medical device. So around 100 and more, they are being approved approved on yearly basis. And then I was trying to look into the list. I have seen again most majority were related to the radiological field and other various specialties, but majority was radiological. The future, again, now coming to the hematological disorders, I think soon it will be integrated to help really support the hematologist decision. Again, to support. Several studies have shown that it can be integrated to differentiate cells, reliably detect malignant cells population, support your chromosomal analysis, again, interpret genetics. So as we can see, it can be used in the various steps which are related to the hematological disorders. As histopathology, it is usually a pathologist-based or a skilled hematologist-based. So they can always be variability. So what if we have now a really AI-based technology that can give us less bias about these features? And also when it comes to the flow cytometry, again, when it comes to, as we mentioned, the chromosomal abnormalities, and some of them are very important for them, especially in the oncology, for treatment decisions and risk against risk and prognosis. And again, back to the genetic disorders, because many, again, of the hematological disorders, they can have genetic background. So it can help us in the various parts of the genetics, whether it is the variant interpretations. And now as we are going to the multi-omics era, not only the genomics, the proteomics, the transcriptomics, so there's a so there is more omics coming over. Just again, I'm telling you, it is used in various specialties. I have seen it has much of concern in ophthalmology. They are using it in even the list I have reviewed many for the early diagnosis of diabetic retinopathy, because they have AI algorithms that can quickly analyze retina scans, such as microaneurysm and hemorrhages and exudates, which will help to early diagnose these cases. Not only in these fields, and even it was in the public health, AI was one of the striking examples that was used in the COVID era, where it helped us, it helped many institutions that they have used it to really predict what are the demographic, the clinical, and the epidemiological characteristics of the patients and what to track. So they can really estimate how much will be the resources that has to be allocated. Again, because it is widely used in the radiological, it could help them. It helped them actually to quickly analyze CT scan and X-rays. So again, it was used in the various fields. Lastly, I will go through some of the limitations that AI. So again, every coin has two sides, and so does AI. So no improvement usually. You can't have much of how much ever task you give them, very specific task, they are still unlike humans. They cannot really struggle with the new situations. No human replication can be done whatsoever with AI. There is absence of creativity. Machines are rational, but they are very inhuman, and they don't possess emotions. There is no morals into it. They don't know what is ethical and what is illegal. So you are the one who have to integrate it properly, but don't forget the ethical and moral issues that are associated with it. So you have to use your which is really helpful. High cost, it doesn't come without a cost. Apart from the installation, there is the repair cost, the maintenance cost. These softwares definitely has to be always updated and upgraded. Unemployment, it can be also one of the severe effects that it can cause. Imagine if you will be started using all machines in future, humans might lose some of their jobs. However, despite these limitations, we cannot ignore that AI will continue to be an important part and in improving in our industrial healthcare field. Thank you. I'm ready for any questions.
Thank you so much, Dr. Mariam, for the excellent and very impressive presentation about the AI use in the genetic diagnosis. There is no questions for you, so we'll move to the next speaker. Our next speaker is Dr. Iman Jassim. She is a graduate from Arabian Gulf University. She did her residency and fellowship at Westmead Hospital, Sydney, and King Khalid University Hospital and King Faisal Specialist Hospital, Riyadh. She's fellow of King Saud University Fellowship and American Society of Clinical Pathology International Specialist. She's a senior consultant at Hematopathology at the Government Hospital, Salmania Medical Complex. Welcome, Dr. Iman.
Thank you, Dr. Najat, again, for having me twice for this conference. I'll go direct to the our speak today about the autoimmune hemolytic anemia, and I'll make it very excitement. I'll start with a case, short case. A 12 years old boy had been presented to the local pediatric hematology oncology with the hemolytic anemia. But at the presentation time, he had anemia, fatigue, jaundice, and splenomegaly. The lab showing that low hemoglobin of 73 or 7.3 with elevated reticulocytes count 5.5 and LDH high, uric acid high. So at this time, when he was presented with low-grade anemia, the DAT was negative. And he was transfused with the unit of red blood cell, but still the hemoglobin is low. Further investigation done for this patient because he had a significant splenomegaly and the uric acid is high. So we won't rule out the malignancy such as lymphoma because of splenomegaly. He went under the CT of chest, abdomen, pelvis, revealing that hepatosplenomegaly and several mesenteric lymph nodes. PET scan was negative, but this lymph node showing benign reactive hyperplasia after removal for the histopathology. Further work with, we have to rule out other hereditary hemolytic anemia. Next generation sequencing was done for the disorders of red blood cell membrane, red blood cells enzymopathy also was screening, and all were negative. Still, the patient is having anemia and having hemolysis. Flow cytometry for paroxysmal nocturnal hemoglobinuria was done, and it was negative. The ultrasound of abdomen with Doppler confirmed that there is enlarged spleen, but there is no evidence of thrombosis. And peripheral blood smear showing spherocytes, microspherocytes, which is seen in all hemolytic anemia. Does not give us the reason why this patient is having hemolytic anemia for 1 year almost, with enlarged splenomegaly. Polychromasia, spherocytes, microspherocytes have been seen on the peripheral blood smear. Osmotic fragility shows that there is a spherocytes, and as I said, that spherocytosis will be present in all hemolytic anemia. This picture was seen, we think of warm autoimmune hemolytic anemia should be excluded. But how? And the DAT was negative. How to overcome that negativity? By extending DAT or super Coombs test, which is not present in all centers, medical centers. The basic DAT test is to examine the red blood cell with IgG, but the extended will be examined for IgA and other IgG. And the red blood cell, if they attach to the low affinity of immunoglobulin, will be washed with other solutions, such as low-strength solution. And after that, the super Coombs test was positive. The extended, it was positive, but the basic is negative. So this patient was diagnosed as conventional or basic DAT negative warm autoimmune hemolytic anemia. And with that, we will start with autoimmune hemolytic anemia and how to overcome negative Coombs test with autoimmune hemolytic anemia. This patient was diagnosed with, as I said, DAT negative, basic DAT negative, but with the extended super Coombs test, it was positive. And treated. It treated with sirolimus. And after 4 months, the spleen is getting smaller. So we will start today about after this background of the history or the case, clinical case, going through the clinical case, that autoimmune hemolytic anemia are divided to the warm autoimmune hemolytic anemia called agglutinin disease, mixed autoimmune hemolytic anemia, paroxysmal cold hemoglobinuria, and atypical autoimmune hemolytic anemia. And our patient was having warm autoimmune hemolytic anemia. With the epidemiology, it's a rare disease. The cold, the warm, it's a rare disease. It could be for the cold and the warm, idiopathic or secondary. So the etiology of the autoimmune hemolytic anemia, it could be primary, idiopathic, or secondary to any reason. One of these reasons could be viral infection, could be bacterial infection, it could be parasites infection, or it could be after bone marrow transplant or solid organ transplant. Because of immunosuppression, a patient will develop something of imbalance in the central and peripheral immunity. And as I said, that cold disease, it could be secondary to the solid malignancy, infection, autoimmune disease, or post-allogenic transplant. All of them, it could be secondary to the bacterial, viral infection, malignancy, CLL, lymphoproliferative disease. It could be secondary to the medication. Some of the medication will cause our body to make autoantibodies against red blood cell membrane. And we will come through how the environment, how the infection, how the drugs, and how the disease will stimulate our immunity to cause autoimmune antibodies. So for the diagnosis of autoimmune hemolytic anemia, as we went through the clinical case, we can do the peripheral smear, which will show us spherocytes, microspherocytes for all hemolytic anemia. This is the finding: reticulocytes count, lactic dehydrogenase, haptoglobin, indirect bilirubin, direct antiglobulin test, or indirect antiglobulin test, bone marrow examination. The direct antiglobulin test, which is that, the basic DAT is a monospecific antiglobulin are used to detect autoantibodies directed against immunoglobulin, particularly IgG, for the warm autoimmune hemolytic anemia, mostly caused by IgG. So it is monospecific to IgG1 or IgG3, and fragmentation of the complement C3d and C3c, or both. Sometimes these antibodies are of low affinity. So when we testing these red blood cells for the antibodies, it will go through the with the washing. So to come over this, we have to use the low. To come over this, we have to use low isonic strength solution. The extended kit contain anti-IgG, also monospecific antibodies, and anti-IgA, anti-IgM, anti-C3d, and anti-C3c to detect other antibodies. As I said, it is the same for our case. For that confirmation or other indirect Coombs test or indirect that, we examine the patient's serum or plasma for indirect antiglobulin presentation in the serum and plasma. For the cold, usually it's caused by IgM. And when we examine it, it will be free. It is not attaching to the red blood cells. So we have to examine it by indirect antiglobulin test. And confirmation with donor erythrocytes. This is the showing how we examine the direct antiglobulin test and indirect antiglobulin test. Direct antiglobulin, we examine direct the red blood cells, which is coated by these antibodies. In indirect, we examine the serum with the donor erythrocytes, and we see how it is agglutinate. Is the bone marrow examination is indicated in these cases? Usually they said no. But if we are suspecting lymphoproliferative disease, CLL, yes, it is indicated. As I mentioned that warm autoimmune disease or warm autoimmune hemolytic anemia is caused by class IgG and complement, and which react at 37 degrees centigrade, which is the normal temperature of the body. And the process will be extravascular in the spleen. That's why the spleen is enlarged in most cases. Additional to the IgG antibodies also have the ability to weak activate complement and deposit C3 fragments on red blood cells, which leads to destruction by Kupffer cell in the liver. If the C5b9 is activated, so the intravascular hemolysis will be seen or noted. This shows that these red blood cells are coated by IgG antibody. And when it is coated by IgG, it will go to the liver, remove part of the red blood cell, remove the part which is coated by the IgG, and become microspherocytes or spherocytes, and will be back to the circulation. In case sometimes that the complement activated, the C3 activated, it will be homolyzed. In case C5b9 is activated, it will be sorry. It will be, in case of the C5b9 is activated, it will be removed in the intravascular. It will be removed in the intravascular as well. But mainly for the IgG, mainly for the worm, is removed in the liver. It's extravascular hemolysis. This just to come over the serology and the identification of the antibodies and the complement detected and causing the hemolysis. For the warm, as I mentioned, warm autoimmune hemolytic anemia is IgG mostly, rarely IgA or IgM, and typically detected by that IgG or IgG-C3, called antiglobulin disease is immunoglobulin M, IgG-M and complement. PCH is biphasic IgG, mixed IgG and IgM, and C3. Is there a risk for the autoimmune hemolytic anemia? It says that yes, it is increased with age. It's increased with the CLL, with lymphoma, with malignancy. And this happened because of, this is a very busy slide. I'll go through the pictures. And this has happened because of, there is imbalance between, the central peripheral immunity and the T regulation cells. As we know that there is some environmental effect when these red blood cells passing through the blood vessels, it creates some of the shear stress. The shear stress will change the band 3 on the red blood cell membrane, create some deformity. This deformity in some patients will cause antibodies to be released and attached to the cell membrane of the red blood cell. Here showing that this is an artificial blood flow or artificial environments when the red blood cell passing through the stress, that some deformity happened to the red cell membrane, causing these IgG or IgM to be attached to the red cell membrane. And then it will be identified by the macrophages in the liver and remove this part of the red cell membrane. This is number one. Number two, release of microvesicles, release of these microvesicles and attached to the red cell membrane. These are microvesicles. These microvesicles attached to the red cell membrane, creating also some changes and deformity in the red cell membrane. And this makes the T cells, B cells, recognize these cells as abnormal cells and creating more of antibodies to against the normal red cell membrane. And the imbalance happen usually in our body because of either idiopathic or some disease at the background, like lymphoma cells, like CLL, plasma cell, multiple myeloma. There is imbalance in production of these antibodies. This diagram showing that in the cold antibody is IgM, which is peptide. The IgM has characterized by multiple binding sites, so it can bind to different red blood cell at the same time. When it is bind to the red blood cell, it will cause activation of the complement pathway C3, usually C3, C3b, C3c, and it will be removed by Kupffer cell again in the liver. It is extravascular hemolysis. But in case of activation of C5 to C5b, C59b, so it will be removed intravascular. I'll just go through this, a busy slide, which is explain that the role of T helper type 17 in the development of inflammation and autoimmune. Usually, this T17 is under regulation of CD4 and CD25. Sometimes we have dysregulation or imbalance between these two cells, leading to increase of T helper 17 in patients with autoimmune hemolytic anemia. This will create increase of the autoimmunity and inflammation. Release of interleukin 17 as well have been seen, and this interleukin will activate the complement pathway as well. So the imbalance between T helper 17 and T regulation cells like CD4 and CD25, sometimes it is non-specific. Sometimes we have genetic predisposed to this pathway. And these two studies speak about the release of microvesicles, the microvesicles which attach to the red cell membrane, either by the environments or by autoimmune or by any acceleration in the plasma cell or lymphocytes. Again, this is the environment stress and microvesicles. And with this, we speak about the pathogenesis of autoimmune hemolytic anemia, the warm and cold. And I'll just go through the future prospect of autoimmune hemolytic therapy. If you just bear attention with me that understanding the autoimmune hemolytic pathogenesis with a new effect of therapies. The target of new therapies mainly B lymphocytes, T lymphocytes, and complement cascade. As we have seen that it is playing the main role in the pathogenesis of autoimmune hemolytic anemia. And also, they are concentrating or pointing on spleen tyrosine kinase, on macrophages and fragments and receptors present on these cells, endothelial cells and macrophage cells. Still, it is under the clinical trial of the therapy. This diagram showing that the different cells we have and what is the presence of the medication, which is target therapy, and what is the future also. As we see that these cells are playing a major role in the autoimmunity or immunity as well. The T cells, B cells, macrophages, parenchymal cells, and plasma cell. As I mentioned that with elderly, the increased risk of multiple myeloma, of lymphoma, imbalance between the T regulation and imbalance between the T17 and increase the maybe the risk for autoimmune hemolytic anemia. Our case is treated by sirolimus, which work on the T cells. And this medication is available, which is target B cells, and plasma cell also available, and the macrophages for the future. I'll go through the conclusion, and if you give me 2 minutes, I'll go through the epidemiology of the autoimmune hemolytic anemia. Autoimmune hemolytic anemia, as we have seen, that it is a rare heterogeneous group of disease. Despite the wealth of research on its pathogenesis and treatment, there are still many issues to be resolved, still many issues because we don't know the main reason. It's still idiopathic for us. The complex diagnostic and treatment of autoimmune hemolytic anemia require individual approach. There are different cases, and we have refractory cases and recurrent sequential treatment lines are used. autoimmune hemolytic anemia is still a disease that causes difficulties in treatment, and this is why it is important to develop research into new drug group in the autoimmune hemolytic anemia. Research into new drugs in the treatment of autoimmune hemolytic targeting B cells and plasma cell T cells and macrophages is developing intensively. An increase in knowledge of the role of the complement, as we mentioned, in autoimmune hemolytic anemia has contributed to the development of drugs that inhibit the complement pathway at various levels. It would be advised to keep autoimmune hemolytic anemia registry in each country because it is different. And by this, we can go to the epidemiology and see little bit, as we know that now there are paroxysmal, cold, and warm. This is the autoimmune hemolytic anemia, again, classification to the warm, cold, mixed, paroxysmal, and atypical. Epidemiology, it is currently estimated incidence of 1.77 cases per 100,000, which is a rare disease. Although the warm autoimmune hemolytic anemia is most common from and account to 2/3 of the cases, it is more common among female than male. Cold is the second most common disease in the autoimmune hemolytic anemia of approximately 15 to 20%. Cold is usually occur in elderly people above 50 because it is attached with the lymphoma, multiple myeloma, non-Hodgkin disease. Paroxysmal cold hemolytic anemia is a rare disease and mostly affecting children. It is rare, it is extremely rare in adults, and it is often associated with infection in this age group. The warm autoimmune hemolytic anemia classified to the idiopathic, primary, and secondary. The secondary to systemic lupus erythematosus, lymphoma, CLL, and some infection and some medication like methyl-dopa and levodopa. The warm autoimmune is primarily removed by the spleen extravascular hemolysis. It is maybe fatal, and sometimes if it is severe, it is caused by IgG. Most of this IgG is pan-agglutinin and have limited specificity to the RH on the red blood cell membrane. Some medication will stimulate the autoantibodies against RH, like methyl-dopa, and cause autoimmune hemolytic anemia. The cold agglutinin disease, it's either idiopathic or secondary to infection like mycoplasma pneumonia or infectious mononucleosis. Lymphoproliferative disease, antibodies are directed against I antigen on the red blood cell membrane. As we mentioned, that it reacts below the 37 degrees centigrade, below the normal temperature of our body, or sometimes need above 30 degrees centigrade, which cause clinical manifestation. Sometimes detection of these antibody need to be thermal amplitude, and it is important than the titer on the DAT. The higher temperature, the closer to the normal temperature, it will cause more hemolysis. If these antibodies are sensitive to the higher temperature, so it will cause more hemolysis. Infection tend to cause acute disease, whereas idiopathic cause be common in the elderly, as we know that they are chronic disease will be present more in the elderly, lymphoma, multiple myeloma. The chronic hemolysis occur largely in extravascular, even in cold agglutinin disease, mainly if the red blood cell is coated with antibodies, it will be removed by the Kupffer cell in the liver. but which is extravascular hemolysis. But sometimes if the complement amplifying condition is activated, so it will be removed in the intravascular. And it is most of the time IgM. Paroxysmal cold hemoglobinuria also is a rare type of cold agglutinin disease, common in the children. Hemolysis results from exposure to cold. Sometimes, even if it is sometimes it is localized, like drinking cold water or washing the hand with cold water. It will cause these antibodies to be attached to the red blood cell on the periphery and will be removed from the circulation. So the hemolysis will be happen. And the paroxysmal also, it is IgG. It's bind to the P antigen on the red blood cell membrane, but it is bind to the P antigen on the low temperature and cause intravascular hemolysis because it will activate the complement pathway, C5b. It occurs non-specific after non-specific viral illness in otherwise healthy patient. It can be seen in patients with congenital or acquired syphilis as well. The severity, rapidity of development of anemia varies because it needs the low temperature to attach. If it has happened in children, this disease, it can be self-resolving, no need for the treatment. And as we went through this table, explaining the second causes of, or the causes can be second causes for the autoimmune hemolytic anemia, the all classification, the warm autoimmune hemolytic anemia, the cold agglutinin disease, and the PCH mixed, and the mixed also autoimmune hemolytic anemia. And this is explaining that is the gold standard for the testing of these autoimmune hemolytic anemia. And if it is negative, we can overcome this negativity by using the extended or the low ionic solution in case of the low affinity of antibodies. And lots of studies about how it is activated, why it is activated, and how it is started has been studied. Why it's more common in the elderly, why it is 5 times higher in the 7th decade of life compared to the 4th. The main reason for this, they said that immunosenses or epigenetic abnormalities. These people, they have accumulated in hematopoietic cells. With aging, numerous comorbidities increase probability and severity of oxidative stress. Lots of study about the release of oxidative stress and how it is affecting the erythrocyte cell membrane and changing of the red blood cell membrane, causing the other cells to cause antibodies against the normal red blood cell membrane, and leading to the coating of these red cell and be removed from the circulation by the liver, or intravascular hemolysis by activation of the complement pathway, especially the C5b. And the genetic background. What is the genetic background? Sometimes immunodeficiency, people with immunodeficiency or autoimmune disease. And as we have noticed that people with SLE or lupus, they are more prone to develop autoimmune hemolytic anemia. Infections, as we have seen, medication, drugs, some anti-cancer drugs, especially for CLL, NHL, and the transplant, post-transplant, all have been suggested as a risk factor for autoimmune hemolytic anemia. And this explains the normal or suggested pathogenesis of autoimmune hemolytic anemia when there is dysregulation or imbalance between the normal CD8-4, CD8, and the regulatory cells, and increase of CD17 against these cells, which increase the risk for inflammation, the risk of autoimmune disease. And these cells, most of these cells release from the T follicular helper cells of the lymph nodes. And there is the dysregulation between these two cells that make the imbalance between the CD4, CD8, and CD17. If the CD17 is high, the interleukin 17 is high, we have increased risk of autoimmunity disease and the inflammation. It is not my field for the treatment, but I'll just go through some hints about the treatment of WOM. It is either targeted therapy, rituximab, or here is a start. Prednisolone is the goal, and then rituximab, splenectomy, or immunosuppressive drug. And this is a future prospect of autoimmune therapy, and we went through some of them. And these are the cells playing the role in the autoimmunity and inflammation. And by this, I can say thank you. I'm ready for any question.
Thank you so much, Dr. Iman, for the excellent and very impressive presentation. As I don't see any question for you, I mean, there is 2 questions for Dr. Dikra. Dr. Dikra, can you answer, please, 2 questions? Dr. Dikra. Then there's one question for Dr. Amani. The question is, what is the incidence of malignancies post-gene therapy treatment? Dr. Amani? Then, okay, so we'll move to the next speaker. Our next speaker is Dr. Tawfiq bin Omran. He is a senior consultant and division chief of genetics and genomic medicine at Sidra Medicine and Hamad Medical Corporation. He is a professor at Weill Cornell Medical College, Qatar, and in New York, USA. He's also a distinguished visiting scientist at Boston Children's Hospital, USA. He contributes to the body of published knowledge in clinical and metabolic genetics with over 200 published articles in peer-reviewed journals, book chapters, and abstracts. He is a reviewer for many clinical genetic journals. Welcome, Dr. Tawfiq.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much. Thank you very much, Dr. Najat, for the kind invitation. It's really my great honor and a pleasure to be part of this very successful conference. You know, I am very impressed with the participants. Like I can see more than 1,000. Mashallah, this is just
more than 1,400.
Yeah, exactly. This is just will reflect the high quality of the organizations, the speakers, and everything. So let me now just to share my screen, please. So as you can see, the title of my talk about unmasking Gaucher disease, a very common and treatable condition. That's why you don't want to miss such a genetic or inherited metabolic disorders. And will be the agenda for my talk. I will be starting with the two case presentations, very informative two cases. Then we'll give a brief overview about Gaucher disease, which I am sure most of the audience are expert and they know Gaucher disease. Then I will be focusing about the reasons behind the diagnostic idiocy that we still see in Gaucher disease. Maybe this is attributed to the lack of awareness. And what is the consequences of the diagnostic odyssey? This is similar for all diseases, but for Gaucher is very important because of this can delay the initiation of therapy. This is very important. And also we will be discussing at the end, is Gaucher disease eligible to be included in the expanded national newborn screening program? And I will end my conclusion by some challenges we faced in general for inherited metabolic disorders. Will focus more on Gaucher disease. So let me just start with this 6 years old young girl, as you can see in the photo. I saw her almost now 8 years ago. Currently, she is around 14 years. And the history, she was born normal to a paternal first cousin parents. And this is her clinical problem. She had growth deficiency, failure to thrive. When I saw her, she's very unhappy, irritable. You cannot really touch her or examine her. I had a difficult time into taking this photo. Also, she was complaining of bone pain, arthralgia, easy bruising, episode of epistaxis, and hepatosplenomegaly, in addition to anemia and thrombocytopenia. Actually, she was referred not because of possibility of Gaucher disease, but to rule out underlying GI or hepatic etiology. And this is very important here. Immediately when I saw her, I thought of Gaucher disease, of course, and we did enzymatic assay and molecular study, which both confirmed the diagnosis of type 1 Gaucher disease. And we started her on enzyme replacement therapy, 60 units per kg every 2 weeks. And this is the gold standard. So this is her photo when I saw her, as I said, at 6 years. And this is a more recent photo. At this photo, she was 12 years old. As you can see, she is completely normal. She is very happy. She's doing well at school. You don't see any complications. So I think, the diagnosis here is very important, the accurate diagnosis, early initiation of the treatment, and enzyme replacement therapy is really changing the natural history of this devastating disease. On the other hand, this is the second case I will present here. This young boy was referred to the metabolic clinic, again with hepatosplenomegaly for evaluation and metabolic genetic testing. So he was seen on a routine well baby visit at around 8 months of age, and the pediatrician discovered that he has hepatosplenomegaly. As you can see, he ordered ultrasound abdomen, and it confirmed the hepatosplenomegaly, so referred to the genetic metabolic clinic. At that time, his development was normal, no skin rashes, no eczema or ichthyosis. Parents are not consanguineous, but this is very important, and usually I ask parents if they are from a small town, and this is the case, so we consider them as consanguineous. When we saw him later, his speech wasn't clear, and they enrolled him in a nursery at that time. He looks good, and however, there was slow walking with normal paces. We didn't notice any abnormal movement. He was alert, but he has strabismus, as they mentioned, hepatosplenomegaly, and on eye exam, there was a deviation of both eyes, slight bilateral upward movement, but there was no horizontal or vertical saccades. Negative Gower sign, tone was normal without clonus or any dystonia. Again, we thought of Gaucher disease, but here maybe, the neuronopathic type because of some neurological and developmental delay. And indeed, the enzyme assay came back low, and also gene study thought by allelic pathogenic, homozygous pathogenic variants. And this variance, it's associated with neuronopathic, likely type 3 Gaucher disease. Again, started on enzyme replacement therapy, and was recently with improvement and stabilization, recently seen by ophthalmology, still having alternate esotropia, seen by pulmonary, and he doesn't have any pulmonary manifestation. Also seen by cardiology, and echo was normal. Seen by ENT, had adenoid hypertrophy, but no sleep apnea, so there was no surgical indication. So this is 2 cases just to highlight the main manifestations of either type 1 Gaucher disease or type 3 Gaucher disease, and how treatment, especially for type 1, it changed the natural history of this devastating disease. So now we'll be talking about historical milestones for Gaucher disease. As you all know, it's first described by Gaucher, who actually was a dermatologist, but he saw this young lady with splenomegaly, and Gaucher himself, he thought of a splenic cancer, and he published this finding in his PhD thesis. More historical landmarks. So the enzyme discovered by Dr. Brady, and it showed that it's due to glucocerebrosidase deficiency. And perhaps about 20 or 30 years later, there was enzyme replacement therapy, and that time it was developed from a placenta. So you can imagine how many placenta you need to use to produce enzyme replacement therapy. And 3 years later, there was the first recombinant enzyme replacement therapy in 1994. So Gaucher is considered perhaps the first in lysosomal storage disorder to have an enzyme replacement therapy. And this is the photo of the first child received enzyme replacement therapy. And in the bottom photo, you can see him. He has a family, and he's the president and chief executive officer of the National Gaucher Foundation. So just quickly, some important points about Gaucher disease. As I mentioned, it is considered as one of the lysosomal storage disorders. Actually, it is the most common type. It is a progressive disease because of the accumulation of the substrate. It involves multi-system and can lead to really debilitating and life-threatening complications. It is an autosomal recessive inheritance. That's why consanguinity and large family size play an important role in its incidence and prevalence, and this is the case in our region. It is due to deficiency of acid beta glucosidase, or the other name is glucocerebrosidase, and this is because of biallelic pathogenic variants in the GBA1 gene. And this deficiency leads to progressive accumulation of the substrate glucosyl ceramide in the lysosome of macrophage cells. So this is basically the underlying pathophysiology, and this is actually it's generalizable to all inborn error of metabolism. So you have a deficiency of the enzyme, and this deficiency leads to the progressive accumulation of the substrate. Here in Gaucher disease is glucosyl ceramide, and this is lead to a progressive multi-organ dysfunction. And in Gaucher disease, especially type 1, involving the reticuloendothelial system, but also in the other types, as you can see, CNS can be involved as well. So again, Gaucher disease, and this is perhaps similar to all other lysosomal storage disorder, is compromise a phenotypic continuum. So we have in the most severe end perinatal lethal, and we have at the most attenuated phenotype, which is type 1, and there is many affected patients are symptomatic until 60 or 70 years old. Even within one family, you can have a brother or a sister with a typical presentation and another brother or a sister who is completely asymptomatic. So this is basically the major phenotypes for Gaucher disease. So we have type 1, which is non-neuronopathic. Type 2 is the most severe acute infantile form. And we have type 3, which is in between, which is subacute and juvenile. We have the extremes phenotype, as I mentioned, the perinatal lethal form, which can present intrauterine as hydrops fetalis, or soon after birth as a collodion baby. And we have the cardiovascular form, which is mainly present with aortic valve problem, maybe mild splenomegaly, and other minor systemic complications. So this is what you need to see in children. In general, if the children presented with Gaucher, sign of Gaucher disease, it means that it's a more aggressive disease than adult form. So you need to look for marked splenomegaly more than hepatomegaly, easy bruising and bleeding, mainly epistaxis, recurrent epistaxis, can present with delayed pubertal development. As I mentioned, also failure to thrive and growth deficiency. And usually children with Gaucher disease, they are very unhappy and very irritable. As opposed to the adult, and this is where the diagnostic odyssey is more. They can present with fatigue, again, easy bruising, bleeding, menorrhagia for females, decreased appetite, and abdominal pain. Now there is expanded in the phenotype. There is also increased risk of gallstone, increased risk for Parkinsonism, even for heterozygous, I mean for the parents, and also increased risk for multiple myeloma and other malignancies. And this is just to show you the difference between the three phenotype, type 1, type 2, and type 3. So what are the barriers of diagnosis? And that's why Dr. Najat chose this talk. So I think decreased awareness is perhaps the main reason for the diagnostic odyssey. So many healthcare professionals, either they have no experience or minimal experience. So this is crucial to have a high index of suspicions if you have children with hematological or hepatosplenomegaly. And there is also sometimes there is a suspicion, but there is minimal evidence regarding how the diagnosis is confirmed. So basically, early referral to metabolic specialty is very crucial. And this is just to see, for example, the main delay in Gaucher type 1 diagnosis in USA about 4 years and about 3 years in Australia and in New Zealand. And usually patients generally seen by 8 different physicians before the diagnosis is confirmed. And a survey among hematologists and hematologist-oncologists, only 20% consider Gaucher disease in their differential diagnosis. And as we can see, the diagnostic odyssey can lead to severe and irreversible clinical problems, mainly pathological fractures, life-threatening bleeding complications, growth deficiency, and sometimes patients can have inappropriate procedures like splenectomy and doing liver biopsy, looking for the treatment. So why early diagnosis is very important? I think this is very clear now. You need an early diagnosis, number one, for early treatment, early initiation of enzyme replacement therapy before irreversible damage happens, mainly bone complication. Also to offer genetic counseling and preventive strategies like pre-implantation genetic testing. And this is, I think, the main message here. If you see patients with splenomegaly and or thrombocytopenia, or if you are thinking of these differential diagnoses, please consider Gaucher disease in your differential diagnosis. So now it's more easy to diagnose Gaucher disease. Nobody doing like bone marrow aspiration. Simply you can do enzyme assay either in dried blood spot or whole blood samples, and you can confirm the diagnosis by gene mutation analysis. Another important biomarker called lyso-GL1. This is not only to diagnose the patient, but also it will give you an idea to whom you should give priority to the treatment, and also important for the follow-up when you have a patient on enzyme replacement therapy. So what about therapy? We know, of course, symptomatic treatment is very important, but there is the gold standard for Gaucher disease is enzyme replacement therapy. And now there are 3 enzymes approved for Gaucher disease. There is also substrate reduction therapy, also approved, but I can say with certain indications. Also allogenic hematopoietic stem cell transplantation, either as adjuvant or if the enzyme and substrate reduction therapy fail. We have other treatment like chaperone therapy, gene therapy, and genome editing, which we heard in the previous lectures. This is just to give you an idea about the underlying mechanism for enzyme replacement therapy. It's very easy. Just you replace the deficient enzyme. And for substrate reduction therapy, just to prevent the formation of the substrate accumulation. What about including Gaucher disease in the newborn screening? Here in Qatar, we still thinking to consider Gaucher disease and other lysosomal in our expanded newborn screening program. This is the advantage, and we mentioned this already, early diagnosis, early treatment to provide more effective genetic counseling, of course, preventing the recurrence in the family, reduces the stress associated with diagnostic odyssey, and also allow prediction of the phenotype in some patients. Of course, what is the disadvantages you will be facing with the late onset phenotype? Especially, we mentioned there will be patients reaching 60 and 70 years old, completely asymptomatic. So what to do with this cohort of patients? Of course, false positives, giving like extreme parental stress and anxiety, and the treatment accessibility, giving that enzyme replacement therapy is still a very expensive medication and not readily available for all patients. So you need to consider all these factors before you include Gaucher in your newborn screening program. Just I will end with some beliefs and practices in our culture here, either in the Arab culture or in the Gulf region culture, because most of the lysosomal storage disorder, including Gaucher disease, the children they are normal at birth with normal growth and development for some time. So when they develop the symptoms, most of the parents, they say this is maybe because of the evil eye, maybe because of the witchcrafts, or, because of jinn. And this is sometimes preventing the families from seeking a medical advice, and this lead to a delay in the diagnosis and in the treatment. In general, autosomal recessive diseases are often hard for the family to understand. The first question the families and parents ask us, we never seen this disease in our family. How comes you say now you have this genetic disease? Also, we have some culture habits that the family hiding the diagnosis from extended family member. So this is also will lead to diagnostic odyssey in other extended and other at-risk family members. Sometimes they become non-compliant with enzyme replacement therapy because they don't need any of their relatives or friends to know about the disease, especially for female patients. For example, I have a family, they agreed to treat the boys, the males, but they refused to treat females. And also some families, they refuse to have home infusion therapy, which is more convenient because they don't want anybody knows about this disease in their children. So my conclusion, I think lack of awareness is very important, and that's why we are having this excellent conference and giving this presentation. I think the ultimate goal is including Gaucher disease in the newborn screening program. Especially now we have an important tools to justify this. Still, enzyme replacement therapy is the first line of therapy. And there are a lot of new trials like gene therapy which present new hope for our children, for our families. And by this, thank you very much for your attention. I am ready to take any questions, please.
Thank you so much, Dr. Tawfiq, for your excellent and very impressive presentation, as usual. And I don't see any questions for you. So we'll move to the next speaker, Dr. Saad Ahmed. Dr. Ahmed is a consultant hematologist at the Pediatric Coagulation Center in Children's Health Ireland, Dublin, and he also worked as a consultant in the Irish Adult National Coagulation Center at St. James's Hospital and leads the transfer of care of bleeding disorder patients to adult service. Dr. Ahmed, he was a sub-investigator in the first gene therapy in hemophilia that took place in Ireland in 2019, and currently he is a sub-investigator in multiple clinical trials that are taking place in Children's Health Ireland. Welcome, Dr. Saad.
Assalamu alaikum wa rahmatullah.
Thank
you. I want to start with thanking Dr. Najat and the organizing team of the conference for inviting me. And I hope you will get useful clinical tips from my talk. Just share my screen. Okay, so I'm going to talk about rare bleeding disorders. I have no conflict of interest related to this presentation. I will talk initially about the
Dr. Saad, sorry for interruption. Could you please go for the slideshow?
Okay.
Thank you.
Yeah. So I'm going to first start by talking about the inheritance and the epidemiology of rare bleeding disorders. And then we'll talk about some of the clinical features, how to diagnose rare bleeding disorders, and how to manage patients who present with bleeding, and also patients who require surgery. And then we'll talk about when and how to treat patients with rare bleeding disorders who require prophylaxis. And we'll talk also about acquired rare bleeding disorders. And we'll end up by talking about advances in management of rare bleeding disorders. In terms of inheritance, first of all, when we talk about rare bleeding disorders, we talk about fibrinogen deficiency, factor 2 deficiency, factor 5 deficiency, combined 5 and 8 deficiency, 7 deficiency, 10 deficiency, 11 deficiency, and 13 deficiency. And we also talk about congenital deficiency of vitamin K dependent factors. So this group of disorders are autosomal recessive. But some of the cases of factor 11 deficiency and dysfibrinogenemia may be or can be autosomal dominant. If you look at the table on the top right, and this is the international estimated prevalence of these disorders, and you can see that the most common of them is factor 7 deficiency. And here we talk about the severe cases. So severe factor 7 deficiency can happen in 1 in 500,000. Most of the rest of them, the incidence is 1 in a million, except factor 13 deficiency and factor 2 deficiency, where the incidence is lower. It can be like 1 in 2 million. And World Federation of Hemophilia started a registry of rare bleeding disorders that was started in 2004. And also the European net started a registry in 2007. And you can see at the bottom right, this is the data from the two registries that again show that the most common two disorders are factor 7 deficiency, which happen in 37.5% of the patients in the registry, and factor 11 deficiency is the second most common, and it's 26.5%. But there is a problem with this data because it is from a European net, and also the World Federation of Hemophilia data, half of the patients in that registry are Caucasian. It might not be a reflection of the true international incidence, because if you look, and we know that from like all autosomal recessive disorders, it is more common in areas where consanguinity is common. So it's not Caucasian, it is more common in the Middle East. But the Middle East is not well representative in this registry. And to give you an example of how this registry can be a little bit misleading, the incidence of factor 11 deficiency, so the heterozygous incidence in the Ashkenazi Jewish is 8%. So it's much higher than what is in the registry. In Ireland, we have a big traveler community, and factor 10 deficiency is common in the traveler community in Ireland. And only in our center, like we treat 7 children with severe factor 10 with prophylaxis, and this will be higher than any other European country. And compared to the international incidence of severe 10, this is 4 times more. In terms of clinical features of rare bleeding disorders, we should differentiate between rare bleeding disorders and hemophilia, because we know that in hemophilia, the most common bleeding feature will be hemarthrosis or muscle hematomas, but both are rare in rare bleeding disorders. More common will be mucocutaneous and surgical associated bleeding. The most serious is intracerebral bleeding, and intracerebral bleeding will be common in severe factor 13 deficiency, and that's why neonates with severe factor 13 deficiency will require prophylaxis since the first week of life. There are other clinical features in addition to bleeding in rare bleeding disorders, because we know that there is risk of miscarriage with afibrinogenemia and with severe factor 13 deficiency. And that's why women will require prophylaxis throughout pregnancy if they have these two disorders, and that is to prevent miscarriage. Also, there is risk of thrombosis with some of these rare bleeding disorder. So in this fibrinogenemia and this prothrombemia, there is a risk of thrombosis, not just bleeding, also risk of thrombosis, which is important to note and deal with. In terms of classification, this is also another big difference from hemophilia. So the classification is not similar to hemophilia. And if you look at this table on the right, it's from the paper in Blood that describe diagnosis and treatment of rare bleeding disorders. You can see that for severe fibrinogen deficiency, the severe is undetectable, while mild is more than 1 gram. And same in prothrombin deficiency, to say it's severe, the level of prothrombin need to be undetectable, and similar to factor 5 deficiency and factor 13 deficiency, while to say that the levels are mild in prothrombin, it need to be more than 10%, and that's similar to factor 5 deficiency. For factor 10 deficiency, children with or adults with levels less than 10% or 0.1 IU per mil will have severe phenotype, while more than 40% will have mild phenotype, and then in between, they can have like moderate features. The bleeding severity is not always in concordance with the level. So in factor 11 deficiency, the residual activity does not correlate with bleeding severity. And in factor 5 deficiency and factor 7 deficiency, the correlation is weak. So it's not always easy. So it's not that like, you know, you need to take history of bleeding in addition to the residual level of factor to decide about treatment. And next, I'm going to talk about how to diagnose rare bleeding disorders. The referral will be either because of bleeding features or because of abnormal coag. So the first thing you do is to repeat the coag screen, so check the prothrombin time, activated partial thromboplastin time, as well as fibrinogen and thrombin time. And if the PT or ABTT are abnormal, the next step, we do 50-50 mix with normal plasma. So we take 50% of the patient's plasma with 50% normal plasma and repeat the PT or ABTT, whatever is abnormal. So there's two possibilities. Either it correct, and this means that there is factor deficiency, and then we check for factors, or there's no correction. And we see that a lot in children because of viral infection. They get an inhibitor, and that inhibitor will affect the test, but will have no clinical significance. And we know the pathway, the clotting cascade. So if there is isolated prolonged PT, this will mean that the deficiency is factor 7 deficiency. If it's isolated prolonged ABTT, then this means that likely it is deficiency of either factor 8, 9, 11, or 12. We know that factor 12 is not clinically significant. So if we excluded 9 and 8, then this means that this patient has factor 11 deficiency. And if both PT and ABTT are prolonged, this may indicate deficiency in factor 2, 5, or 10, or deficiency in both extrinsic and intrinsic pathways. Now, if we confirm that there is deficiency in one of the clotting factors, the next step depends on the factor deficiency. For example, in hypofibrinogenemia or low fibrinogen, and in low factor 2, we need to identify if the patient has dysfibrinogenemia or dysprothrombinemia, because there is thrombotic risk. So we need to do antigenic assays. And also in factor 13 deficiency, we will do antigen assay, and that is important because we need to know what is the subclass. Is it subclass A or subclass B? So subclass A is more common and more severe. Subclass B is the genetic problem will be in the carrier site, and it is less severe, but it is much rare compared to subclass A. And then molecular diagnosis can also be used, but only in selected group of patients. And in terms of management for rare bleeding disorders is usually on-demand treatment. So the number of patients on prophylaxis will be much less compared to hemophilia. And in terms of what to treat with and what is the dose, first of all, the treatments for rare bleeding disorders compared to hemophilia is suboptimal. So in rare bleeding disorders, we have only 2 recombinant factors to date. That is recombinant 7A and recombinant factor 13. So all the factors are still plasma-derived. Also, there are like factors deficiency where there is no concentrate. So for example, for factor 5, we still use plasma. And for factor 2 deficiency, we use BCC, so prothrombin complex concentrate, as the treatment of choice because there is no specific factor concentrate. So if a patient or a child presented with bleeding who has like hypofibrinogenemia, the treatment of choice will be giving fibrinogen. And for bleeding, the usual dose for fibrinogen to treat bleeding will be 50 to 100 milligram per kilogram. And you want the level to be about 1.5, the trough to be above 1. And then factor 7, which is the most common, we have recombinant 7A, and the treatment for bleeds will be up to 90 microgram per kg. It had very short half-life. So Novo7 or recombinant 7A is used every 2 hours in patients with severe bleeding, and then you can reduce the frequency. In terms of factor 10 deficiency, there's recently a licensed factor 10 concentrate that's called Coagidex. And if it is not available, then prothrombin complex concentrate can be used. For factor 11 deficiency, there is a problem with factor 11 concentrate, which is licensed in some countries, but not in all countries. And that is in factor 11 deficiency, there's very high risk of thrombosis with factor 11 concentrate. So many international use plasma and tranexamic acid instead of using factor 11 concentrate. And again, for factor 13 deficiency, there is a recombinant factor 13, but recombinant factor 13 can only be used if the subtype is A. So you cannot use it for subtype B. But for example, in Ireland, we don't use recombinant factor 13. We only use plasma-derived factor 13. In terms of prophylaxis, as I mentioned before, it is very rare to use prophylaxis in rare bleeding disorders. But some of the types of rare bleeding disorders will require prophylaxis early in life. If you look at the bottom of the table, factor 13 deficiency, which is very rare, but it requires prophylaxis because there is high risk of intracerebral bleeding in neonates with severe factor 13 deficiency. The good thing about factor 13 is that the factor 13 concentrate has long half-life. So the half-life is 1 week, so it can be used every 4 weeks for prophylaxis. The other factor deficiency that require prophylaxis early in life will be factor 10 deficiency. And we have very good experience with factor 10 deficiency because of high incidence in Ireland. So at the moment, we have like 7 children who get regular prophylaxis because of severe factor 10 deficiency. And we usually start the prophylaxis like immediately, like in the first week of life. And we use factor 10 concentrate, it's called Coagidex, and they will need prophylaxis 3 times per week to keep their trough more than 5%. Children with severe types of hypofibrinogenemia, like children with afibrinogenemia, will also require prophylaxis, particularly if they develop bleeding early in life. And they will need then fibrinogen. That will be the treatment of choice if available. And that can be used weekly. and the dose is 30 to 100 milligram per kilogram. The use of prophylaxis on the other types of coagulation factor deficiency is much less common. But obviously, if you have a child who develops severe bleeding or recurrent bleeding episodes and he has low levels of factor, then secondary prophylaxis should be considered. And Professor Yutaka Okamoto, who died in 2016, she is a Japanese scientist who in the 1950s invented tranexamic acid. And the reason why she wanted to invent tranexamic acid is to reduce the risk from postpartum hemorrhage. So that is the initial drive for her. And people initially didn't recognize her work. And it took a long time for people to recognize how important is tranexamic acid. Tranexamic acid is an antifibrinolytic that works very well in mucous membrane bleedings. So it has a high concentration in mucous membranes. So things like nosebleeds, heavy menstrual period, it will be very effective. And there's wide use of tranexamic acid in bleeding coagulation centers now. So if there is a patient with mild bleeding disorder who is going for a minor surgery or has a minor bleed, then tranexamic acid will be the first line of treatment. And it can be used as a mouthwash in dental procedures. It can use as a tablet, and it can use by intravenous method if we need to give it urgently, like for bleeding. So 1 year after Dr. Okamoto died, they published the result of the use of tranexamic acid in postpartum hemorrhage. And now it's part of almost all protocols of postpartum hemorrhage, as well as trauma patients. And in terms of acquired coagulation factor deficiency, we see cases of acquired factor II deficiency that can be associated with antiphospholipid antibodies or SLE. And also acquired 5 can happen after the use of fibrin glue in surgery, and also with association with the use of some of the antibiotics like aminoglycosides and penicillins, and also in patients with tuberculosis. Acquired 13 deficiency also reported in patients post-cardiac surgery, inflammatory bowel disorders, or Hinch-Schwann-Lin purpura. And I want you to always think of vitamin K deficiency. If you have a child who is inpatient, and then you got a consult that he has an abnormal coag. So if that child has a previous normal coagulation screen, number 1 differential will be vitamin K deficiency. And many times we treat those children empirically with vitamin K and repeat the coag screen again. And in most cases, it will correct. So we should be always conscious of low vitamin K. And we know that vitamin K, the main source of it is the normal flora in the gut. So if there is a sick patient getting antibiotic in hospital, not eating greens, then this will all lead to low vitamin K and abnormal coag screen. In terms of advances in management of rare bleeding disorders, as I mentioned earlier, the management and the advances in management in rare bleeding disorders are suboptimal for sure. And that is because companies will not get that much kind of profit from inventing new treatments because they are rare disorders. And still the treatment is by factor concentrate, plasma, or cryoprecipitate for most of them. Still, there is no specific factor concentrate for factor II deficiency and factor V deficiencies. And recombinant factor concentrate only available for factor VII and factor 13 deficiency. So there is an unmet need. What is in the horizon in terms of new treatment? Fitusiran, And we know fitusiran from the studies in hemophilia with or without inhibitor. And fitusiran, which is a small interfering RNA molecule that reduces antithrombin activity, and this will increase thrombin generation. It was studied in vitro in factor 5 deficiency, factor 7 deficiency, factor 11 deficiency, and with success. Also, a study published in Blood this year on the use of fitusiran. So they used mice model, and they could show that fitusiran increased thrombin generation by 4-fold in factor 10 deficient mice. Another antibody is VGA039, which is a monoclonal antibody against protein S. That can be given subcutaneously or IV, and it increases thrombin generation in von Willebrand disease, as well as factor 7 deficiency, factor 8 deficiency, 9 deficiency, 11 deficiency, and 13 deficiency. And you can see the graphs down here, but that is all in vitro studies. So it is early days. Is there gene therapy in rare bleeding disorders? There is ongoing animal studies in severe factor 7 deficiency using AAV liver directed factor 7 or 7A gene transfer, but it's early days and we don't expect any gene therapy in the near future in rare bleeding disorders. So with this, I will conclude, and I'm happy to answer any question.
Thank you so much, Dr. Saad, for the excellent and very impressive review of the rare bleeding disorders. I don't see any questions for you, so thank you so much for joining us, Dr. Saad. We move now to our next speaker. Next speaker is Dr. Al-Zahrani. Dr. Al-Zahrani is adjunct professor in the College of Medicine, Al Faisal University, Riyadh. He is deputy director of the Cancer Center of Excellence and the acting chairman and a consultant in the Department of Hematology, Stem Cell Transplantation and Cellular Therapy Department at King Faisal Specialist Hospital and Research Center. Dr. Al-Zahrani is also the chairman of Anti-Thrombotic Stewardship Program. Welcome, Dr. Zahrani.
Thank you, Dr. Najat. It's a great honor and pleasure for me to be with you. I'm very, honestly thrilled to be part of this very high caliber scientific activity. I see, mashallah, tabarakallah, 1,400 attendees. So congratulations for this excellent and successful annual meeting. Can you see my slide, Dr. Najat?
Yes, I can.
Yeah. So I'm going to talk about PNH. This is my disclosure. And this is a brief outline of my presentation. So as you may know, colleagues, PNH is a progressive life-threatening disease that can cause thrombosis, end-organ damage, and significantly impact and lower the quality of life of patients affected with this disease. It basically is a result of uncontrolled complement-mediated intravascular hemolysis, and with consequent, effect of the PIGA gene as a consequence of PIGA gene acquired mutation in the somatic genes in hematopoietic stem cells. The disease has a very bad long-term outcome if untreated with the appropriate standards of care, which is complement inhibition. And as you see here, there is a progressive decline in the survival of these patients. And you can see that in the old days, 72% of patients died in 25 years compared to the general population, where you see, and even in more recent cohorts, you see a progressive decline in their survival. Luckily, this disease is very rare, and it affects only 1 per million patient, and around 15-year prevalence is around 15 per million. It can be diagnosed at any age, but typically in the mid-30s, and pediatric patients account for around 5 to 10% of cases of PNH. It affects both men and women almost equally. A median survival if untreated patients around 10 years. What is complement? Complement, as you may recall from the medical college, is a set of serum proteins that cooperate with both the innate and adaptive immune system to eliminate invading pathogens and any abnormal tissues. It's a vital component of the innate immune system and has a major role in the adaptive immune system in reacting with the B and T cells. This is how it gets activated, as you may recall, could be through the classic pathway, lectin pathway, and alternative pathway. That ultimately ends with C3 activation, which activates C5 to 2 components, C5a and C5b. C5a is an aflatoxin, and C5b activates other complement proteins to form the membrane attack complex. CD55 inhibits the membrane attack complex and controls it, and CD59, sorry, and CD55 is also another control mechanism to prevent the rapid destruction of normal cells. Trying to move to the next slide. So as you see here, C5 activation leads to anaphylactic features with leukocyte activation, endothelial activation, and a prothrombotic condition. C5 activation leads to cell destruction, inflammation, and thrombosis. The 2 main proteins involved in the pathogenesis of PNH is the CD59, which is the membrane inhibitor of reactive lysis, and CD55 is the decay accelerating factor. These are the 2 proteins, and if you imagine this is the cell membrane, and this is the anchor protein, the GPI anchor protein, which is coded by the PIG-A gene in the short arm of X chromosome. So when this anchor protein is lost, the protective mechanism against complement is lost, leading to rapid destruction of the red blood cells. And the anchor protein also allows and helps in attaching large number of proteins, as you see here, platelets, red cells, granulocytes, monocytes, and lymphocytes, to hold these important proteins on the surface of these cells. So when the patient develops deficiency of this anchor protein with the loss of the protective proteins, the end result is complement activation that can be exaggerated with infection, surgery, autoimmune disease, pregnancy, malignancy, drugs, and a transplant process. This all leads to complement activation and amplification. Patients with PNH will end up having the following manifestations: fatigue due to anemia, and also the depletion of the several plasma proteins. Anemia is a main consequence of hemolysis, is presenting in 88% of patients. Dyspnea, chronic kidney disease, abdominal pain, pulmonary hypertension, erectile dysfunction, dysphagia, thrombosis, and hemoglobinuria. So as you see, thrombosis, kidney disease, and anemia and the quality of life issues like fatigue are the main manifestation of this disease. The thromboembolic events occur both in the arterial and venous system, and it accounts for around 2/3 of the deaths in these patients. and it correlates with the LDH activation elevation, which is a result of red cell destruction, reflecting the disease activity. And the thrombosis also is more likely to occur if the patient has high LDH chest pain or abdominal pain or dyspnea. Chronic renal impairment is also prevalent in these patients, occurring in 2/3 of these patients. And stage 3 to 4 disease affects up to 21% of patients with PNH, and 8 to 18% of patients of PNH die from renal failure. Dyspnea is another very common and important symptom affecting 2/3 of patients, and it may result from pulmonary hypertension or cardiac dysfunction. And nearly 50% of patients with PNH untreated will end up having pulmonary hypertension due to increased vascular resistance and recurrent pulmonary emboli. There is a significant association between morbidity and features of hemolysis, mortality and features of hemolysis, and particularly the marker of hemolysis that correlates with potential death is the LDH elevation. We classify PNH into 3 main types. The classic PNH, which is the misnomer that we name paroxysmal, which is not true. PNH happens actually the hemolysis happens chronically, nocturnal. It doesn't have to be at night. It happens day and night. And hemoglobinuria is only seen around 25% of these patients. Patients with classic PNH develop mainly florid hemolysis with LDH elevation. PNH can also be subclinical, which is the type of PNH that happens in bone marrow failure syndromes and does not require any specific therapy in this situation, and is usually treated by treating the underlying disease like aplastic anemia or hypoplastic MDS. And there is an overlap between these two categories where the patients with hemolysis and also some degree of bone marrow failure may present, and these patients may benefit from complement inhibitors if the hemolysis is evident. Diagnosis of PNH according to the International Clinical Cytometry Society and International PNH Interest Group, the recommendation is to do PNH screening in patients with unusual site of thrombosis, COMS negative hemolytic anemia, and unexplained hemolysis, and evidence of bone marrow failure. And it's almost the same for International PNH Interest Group. And the best way to diagnose PNH is using flow cytometry, assessing the presence of these loss of the anchor proteins and the attached proteins on the granulocytes and monocytes. And it should have a very high sensitivity of 0.01%. And this is using anchor protein, a monocular antibody that attaches to the anchor protein. On the red cells, we directly look for CD55 and CD59. And the protein that is targeted by fluorescent cytometry is in the white cells and monocytes is the flare. This is what we mean by the flare. It's a protein, aeroleucine protein that attaches to the anchor protein, and if it is lost, then the fluorescence is lost in these cells, and it is very helpful in diagnosing PNH because in patients who are hemolyzing and also they are anemic and getting transfused, the number of red cells that are abnormal with regards to the CD55 and CD59 may be significantly diluted, leading to underdiagnosis or missing the diagnosis of this disease. We monitor these patients by evaluating LDH, reticulocyte count, haptoglobin, bilirubin, and renal function, and urinalysis, pro-brain natriuretic peptide for evaluating the pulmonary hypertension, And the annual or semi-annual testing for PNH is important because the clone can evolve and change from low level to higher level, and very rarely the clone can totally disappear. Treatment of PNH involves supportive care in the form of blood transfusion, folate, iron replacement, complement inhibitor is a mainstay of therapy in these patients. We rarely use steroids for a long time, and androgens are sometimes very helpful in, especially if there is concomitant bone marrow dysfunction. With regards to thrombosis, this is managed in the usual way of normally with heparin, warfarin, DUAX, or antiplatelet and antifibrinotics, depending on the fibrinolytic agents, depending on the clinical presentation. And patients with main features of bone marrow failure, they are treated with ATG and cyclosporin or with stem cell transplantation. Now, complement inhibitors have come as the standard of care in PNH patients. And this is the first complement inhibitor that has been introduced in 2007 and approved to combat the symptoms of PNH, eculizumab. The drug leads to significant reduction in the thromboembolic events of 92%. It improves and stabilizes kidney function in 93% and decreases the incidence of pulmonary hypertension. It's very important to keep in mind in patients receiving complement inhibitor to prevent infections like meningococcal infection using prophylactic antibiotics for 2 weeks if you start the eculizumab right away, or if you have time to wait, you can vaccinate these patients. But in our practice, we prefer to use prophylactic anticoagulant antibiotics as long as the patient is on the complement inhibitors. And if patients discontinue eculizumab for any reason, one have to be very careful and observe these patients for at least 8 weeks for the features of acute hemolysis. And during this period, they may require blood transfusion or anticoagulant or steroids, or they may require resumption of complement inhibitors. A more advanced form of complement C5 inhibitor is the ravulizumab, which has been modified to make it more durable in action and give more persistent suppression of the complement activity. And this is through the modification of the FC receptor and the FAB component, making it more able to dissociate from the C5 at the lysosomal pH, allowing the lysosomes to destroy them more quickly, and also allowing it to bind to the neonatal FC receptor to be recycled for its use. So this allows a longer half-life. So instead of 26 hospital visits for eculizumab, ravulizumab is given every 2 months, and 7 visits are required. Initial dose, then 2 weeks later, the subsequent dose is given, and then patients are given the therapy every 2 months. This has led to a significant reduction in transfusion avoidance and the LDH normalization compared to the eculizumab, and it improved the quality of life of these patients, reduced the breakthrough hemolysis, and leads to higher hemoglobin stabilization. And this has been studied in 2 situations, in treatment-naive patients and in patients who have been treated with C5 inhibitor, the eculizumab. And the same thing is seen here in patients with who were originally on eculizumab and treated subsequently shifted to ravulizumab. You still maintain the same efficacy and maybe even better, lower breakthrough hemolysis, some degree of improvement in quality of life and better hemoglobin stabilization and transfusion avoidance. Despite these drugs being very effective, still a good fraction of these patients with PNH on C5 inhibitors still have anemia or even severe anemia. So for this reason, an unmet need was there, which is how can we improve the anemia control in these patients? And in this regard, pegcetacoplan has been introduced which is a C3 inhibitor, and was studied in this phase 3 randomized trial that looked at the patients who have been originally on eculizumab and are suboptimally responding with a mean hemoglobin of around 8, and they treat them for 4 weeks with a combination of pegcetacoplan and eculizumab. And in 4 weeks, you can see a very significant rise in the hemoglobin of these patients who are treated with pegcetacoplan, and those who were who stayed after the 4 weeks on eculizumab, the original therapy, their hemoglobin dropped to their usual baseline. And this has led to reduction in the transfusions, and also you can see the transfusion avoidance is significantly higher in the pegcetacoplan patients than in the ravulizumab, the eculizumab groups. The hemoglobin normalization is much more likely to occur. The reticulocyte count normalization, as you see here, LDH normalization, and the quality of life features are all in favor of pegcetacoplan compared to those who have been on eculizumab and were suboptimally responding to this therapy. The transfusion avoidance is shown also again here, 85% with pegcetacoplan compared to 15%. And the number of units that are required was consistently lower in the pegcetacoplan than the eculizumab. Another study was looking at the treatment-naive patients, which is a Prince study, looking at those who have PNH and have never received complement inhibitors, but were receiving the standard of care except for the complement inhibitors. And this study has shown significant reduction in the LDH and the mean hemoglobin level, as well as transfusion avoidance, being in 91% of patients in pegcetacoplan avoided transfusion compared to those on the standard of care, which very important to keep in mind that these patients were not on C5 inhibitor. Many other new therapies are on the horizon. Crovalimab is a C5 inhibitor that also can be given subcutaneously. And iptacopan is, I think, is now FDA approved in for treatment naive and for patients who have been on C5 inhibitors. Danicopan is also another therapy that is used as an added therapy to C5 inhibitor, and also in treatment naive patients, and has very effective in reducing the hemolysis and improving the anemia of these patients. So, colleagues, to conclude, PNH is a progressive life-threatening disease that causes thrombosis, end-organ damage, and impaired health-related quality of life. It results from excessive complement activation and intravascular hemolysis. And there is a diverse manifestations and symptomatology in these patients that can lead to significant morbidity and death. High sensitivity flow cytometry is the gold standard diagnostic test for these patients. And current therapy includes highly effective complement inhibitors, C5 and C3 inhibitors, and several other new therapies are on the horizon. And thank you very much for your attention.
Thank you so much, Dr. Hazza, for the excellent and very impressive review of PNH. There is one question for you. The question is, what are the signs that help early diagnosis of PNH, and is there seasonal variation in the PNH episodes?
Thank you for the question. I think that's very, very important question. And one of the major problems of PNH is the delay in diagnosis. These patients typically only see hematologists after several other visits to other specialties, including urology, gastroenterology, psychiatry, and several other specialties. So they end up being lost, and some patients may stay for 10 years before they can be diagnosed. So I think these vague symptoms make it also vague too, and being a great mimicker on all of these manifestations make the diagnosis difficult. So early diagnosis is very important, and I think when patients present with thrombosis in any unusual site, unexplained hemolytic anemia, these two and vague symptoms like dysphagia, recurrent abdominal pain, erectile dysfunction are also very important symptoms to think of as possible early manifestations of the disease. Now, regarding the seasonal variation, I don't think there is any, and I'm not aware of any, but I will love to hear the comment of the colleague who asked whether there is any seasonal variation. I don't think there is any to my knowledge, but I'd be happy to look it up and see if there is anything in the literature.
Thank you so much, Dr. Hazza, for this, for joining us today. Now
Thank you.
Thank you, Dr. Hazza. Now we come to we have one announcement. Okay, we come to okay, so this is the announcement. There is the ASCET conference, which will be in UK for those interested to attend. So we come to the end of this conference. Distinguished guest speakers, sponsors, and attendees. We have reached the closing session of our 5th International Pediatric Conference. For the past few days, we have had the privilege of learning from and engaging with some of the best minds from around the world on important topics related to pediatric hematology. Eminent experts from over 10 countries shared their research and clinical insight on a wide range of blood disorders affecting children, such as sickle cell disease, thalassemia, hemophilia, von Willebrand disease, rare bleeding disorder, congenital platelet disorders, febrile neutropenia, thrombosis, and PNH, autoimmune hemolytic anemia, and HUS. We also heard about exciting advancement in areas like gene therapy, AI-powered diagnostic, and personalized treatment approaches that offer hope to young patients and their families, bringing together over 1,500 healthcare professionals and scientists from around the world has allowed for meaningful exchange of ideas, collaboration, and networking. I would like to thank all our guest faculty for generously sharing their knowledge and experience. I also appreciate the active participation of our attendees through insightful questions and discussions over the last few days. A special thank you to our sponsors for making this conference possible through their generous support. Lastly, I want to acknowledge the effort of the organizing committee for meticulously planning this impactful virtual event. As we close this conference, I hope we leave enriched by new learnings and relationships that will help advance care for children with blood disorders. Thank you for being part of this important initiative. I look forward to seeing you at the 6th International Pediatric Conference, inshallah, next year. Importance notice, the CME certificate, it will be after 1 week for those who attended the conference for 3 days. So thank you so much for joining us, and goodbye for now, and see you inshallah next conference.